So the patient echo close to me. So the patient is echo. Yeah, ma'am.
Use this. Let him mute the slides.
It's okay now. Yeah. So this particular patient, And the best method was this pressure cooking, as I mentioned to you. There was a research paper in a national conference, which was awarded based on the data what they obtained after using the different processes of leaching, and they found that the best method was the pressure cooking one, wherein they had it over one whistle, I think, and discarded the water, and the maximum amount of potassium and phosphorus was leached in that particular method, followed by this 3 times boiling.
But was that on a range of foods or just one food?
No, not one food, several
Just
foods.
one.
Several foods. Yes, ma'am.
And my other question was that we tend not to practice leaching to reduce phosphate content of foods.
Okay.
I gather that's common practice here.
Yeah, ma'am.
You haven't mentioned giving phosphate binders
No,
in order to
yeah.
the diet to be more relaxed.
Potassium binders as well as phosphorus binders, both are used here. What we do here is, most often we try and pick up the mistakes what the patient is doing in the diet recall. If they are starkingly high in potassium through processed foods, either potassium or phosphorus, we pull out those processed foods and then check if the serum potassium and phosphorus is better. We leave the patient. If not, if it's compromising the nutrient intake, then no choice but to go on a potassium or a phosphate binder. So it's not the first take.
Yeah, I think our practice is probably a bit different in that we start.
No,
from
it's
phosphate.
the nutritionist has no role to play here in India with reference to phosphate binder or potassium binder.
Okay.
I think the nephrologist here can throw some light on that.
Yeah. Of course,
We would love to have you also in our clinic. We don't seem
No,
to
but we don't
have
take the
people.
call with
Yeah,
reference
yeah.
to binders. We
Yeah,
don't take
and
the call.
often there is no discussion with the dietitian before, can you see if you can reduce the potassium or the phosphate in the diet? Most of us just, okay, this is what I can do. I'm going to add another medicine to your list. We are all, culpable to this. So that's how it's most of the centers. That's what we do, and then sort of give some advice about you can leach some of the vegetables. It's mostly for potassium. Phosphate is news to me as well as I'm going to be leaching. So understand that phosphate also can be leached. Yeah.
I must admit I haven't heard of the concept of phosphate. But then I guess it's the balance of the palatability of the food.
There's so many
For
things.
that
Once,
side.
if the food is, I'm saying the vegetable is leached, I think the palatability comes down really. But then if it's really troubling the patient in terms of the biochemical parameters, we have no choice, and we tell them you add some seasonings, salt substitutes and stuff like that, make it a little more tasty. So we give them ideas like you use amchur, use nimbu, use kokum, use all these things so that the food is more palatable.
I just wanted to say that the phosphate binders, what I practice, and I do admit I have the luxury of excellent dietitians with me. But what I'd say is, for example, that the child needs 5 tablets of calcium acetate a day, just as a random example. Now, I don't think those 5 tablets should be given at fixed times every single day. I think if the patient can be educated on just eyeballing their plate of food, seeing that these are the high phosphate things in it, and then adjusting the binders. So, for example, just as an example, 1 with breakfast, 2 with your main meals.
Yeah.
Half with
Depending on how much phosphorus is walking into your meal, you take it along with it, not space it. Then the
Exactly.
purpose is lost.
And just get the dietitian educating the patient on that might be really helpful. I wanted to ask another slightly separate question. Please don't take this as in a wrong way. I have no liaison with any nutrition company, and I have no interest in it. But we do have a good, palatable, high calorie, low potassium, low phosphate feed. That in my practice makes a big difference.
I agree.
And when they can get their nutrition into this, and it is palatable, so you don't have to have an NG2.
Oh, agreed.
If you
200%.
can consider getting that nutritional supplement here, then it slightly relaxes the restriction on the rest of the diet and might actually allow the child to be a little bit better. So it's something that perhaps yourselves could consider here as the medical team there as well, to consider getting the supplement.
In fact, for our adult CKD, not CKD is without an oral nutrition supplement. In fact, 35% of their calorie and protein is met only with oral nutrition supplement. In fact, they add it to the meal. It's no flavor, no taste.
Talking about the protein supplement.
Yeah, the renal supplements. So we add it to the meal, to the dough, to the batter. So it's tasteless, flavorless, nothing, but it does provide the nutrition required for patients, especially who are undergoing hemodialysis or the more difficult.
And so this is a powder, and that goes a long way in helping, because of course you add it to your food.
Yeah, we make, when you're making your chapatis, you're making your
I
dosa.
think Dr. Meenakshi is speaking about the protein supplement powders
Yes,
that you
I
have,
got
and you
that.
are speaking something different.
The
Isn't it?
protein supplement powder is excellent, I think, and we discussed yesterday that in the over 2-year-olds, you could consider that. What I'm talking about is a feed, so a liquid feed, which is, I think it's 2 calories per meal, but 1 calorie per meal. Sorry, but you mentioned it on your list.
Yeah, 1.5 to 2 calories are available even in India.
You mentioned it on your list as well, Renaissance.
Yes.
So perhaps you could,
They are low in potassium and phosphorus.
For the 2 meals.
Yeah.
and you might want to consider that as one of the drinks or one of the foods a day, just to then relax the restriction on the others.
So this is a Renaissance.
But Remstart is an infant formula. It's nutritionally complete, so it can be used as a sole source of nutrition. But it is very low in potassium, which is obviously it's renal specific. So it shouldn't be used as a sole source of nutrition for more than a day or two, because otherwise the child becomes hypokalemic. But the advantage of having an infant formula powder is that you can then mix it with your normal whey-based infant formula. So you can design a feed specifically for a child. So you can change the proportions of the Renaissance with your whey-based infant formula. So you can change the potassium content of the feed daily if you need to, according to the serum levels that you're getting. And I think if one thing that comes out of this conference is that you could investigate having this particular feed Renaissance available. I think it would really help your practice enormously, particularly with young infants. As Roxana said, if they can be using the Renaissance as a major source of their nutrition, so saying in adults, providing 35-50% of the nutrition, it allows a much more liberal diet, so that we don't have to be talking about bleaching, boiling, etc., because they can eat more normally.
One question about the too. Yes, this boiling the peaks, which is fine for something like potatoes. But for other vegetables, when you boil it 3 times.
The best thing is to pressure cook them and discard the water. It's one shot, it's convenient.
Can you just soak them for
Overnight, you can soak them overnight in warm water or for 4 hours in boiling water. But that's an effort. Meaning, if you're planning to cook now, you've just decided, the mother is running between dialysis centers and taking care of the family, the sick child. If she has to think that she has to do this 4 hours prior or overnight, which is easier to do this pressure cooking. That's what we thought, because this was based on the research paper published a few years ago. But I don't have access to it right now.
So just one more comment about the boiling, the 3 times. What's the texture of the feed like at the end?
It's not so bad, ma'am. It's not so bad. No, it's not so bad. It's about 4 to no potatoes. The best way is to pressure cook them.
Potatoes, if you boil, that in potato roti or make a tikki.
So you're making it more like a mash.
Yeah, mashed potatoes.
Yes.
Because kids love that tikki thing.
The tikki, aloo ka paratha, masala dosa, they like all those things. Or even you fry it as a French fry.
So the texture after you boil it.
It's not so bad, ma'am. It's not so bad.
Make a mash of it. You don't have to
Even if you grate the potato and boil it, 75% of fat. So that is also, I mean, that's a mash form. So you put it in that.
Even otherwise, even if it is chunk cut,
Then also,
the texture is not so bad. You can actually make a dry vegetable out of it.
Other vegetables that I would.
Only thing I would say, they become a little insipid.
Yeah.
So what I would say is you can manipulate within your meal plan that you can have 1 or 2 portions of moderate and high potassium vegetables. But still you can manage to take it.
Try the other vegetables after boiling.
Yeah, some patients go home with the message that they have to have only the boiled vegetable. They forget that they need to season it. So we do make it a point to tell them that please season it, add your masalas, add your substitutes, which will enhance the flavor of the meal and not compromise the nutrition at the end of the day. Otherwise, the purpose is lost. Then we needn't have a nutritionist talking so much. Thank you so much.
I think that was a lovely session with all of you interacting. Very nice, yeah. Next is Annie. Annie would be speaking on how to manage an infant with chronic kidney disease. That's a really special population. Yeah.
So that's so exciting. That's Dr. Meenakshi, of course, and since she's already covered most part, we'll just be discussing about the case. And the mic will be open for all discussions, right? I would want to learn and know what are you doing in other centers, because that is very much important and that will enlighten all of us.
Video will be You want the video first? Yes, but I'll talk about it and then I'll play. So if you can just load பண்ணி வைங்க. Load பண்ணி வைங்க. You can play from there also. And then நீங்க அதே play பண்ணி வச்சிருக்கீங்க. அதுல தான் ஸ்டார்ட் பண்ண போறோம். இது ஃபர்ஸ்ட் ஸ்டெப். அங்க இருக்கா? சரி ஓகே. நான் சொல்றேன் அப்போ ப்ளே பண்ணுங்க. அதுக்கப்புறம் என்ன செய்யணும்? அதுக்கப்புறம் யூ ஸ்டார்ட் தி ஸ்லைட்ஸ். ரெண்டாவது ஸ்லைட் பண்ணும்போது speak first.
Okay, so just to keep it more lighter, I'll be starting this with one video, a very short, small video. The reason why I'm starting this is because, all of us, I think most of us are students here are still practicing. Are you practicing?
Today, many of them are dietitians, doctors who are actually seeing patients in their practice and giving diet advice. There are some students, especially
So that part are students, the ones who are wearing your college tags. Okay, that's a very nice way to differentiate. Others are all practicing nutritionists and doctors here. So a very important message, I think what we all need in this era is, especially handling our pediatric kids. We do give a lot of counseling, probably for an adolescent child, like what Dr. Meenakshi mentioned. But when it's an infant or a child, who's primarily taken care by parents. So the thing what we really have to think about is empathy, right? Because that is something which I always practice with my fellow students. So I would want all of you to just go through this video. It's a very small 2-minute video. It's not from India, of course, but it gives us a lot of message. So Yes, so here, the whole, the idea of just showing you that video was to just prepare you for the slides what I'll be showing because I was initially associated with St. John's Hospital. Now I'm not working there anymore. It's in Bangalore, it's a multi-specialty center where we get clients from lower economic background a lot. 95% of patients who we see are from that background. The case what I'll be showing today is of a child who's 8 months old with bilateral retro issues. So they could not afford anything basically. So they could not afford the dialysis also. So how do we treat or manage such situations firstly? And secondly, the mother and father were they could not understand what doctors were explaining to them. Though a lot of efforts were made. Kannada speaking was involved because they were initially from Karnataka and they wanted to understand Kannada. But despite that, understanding can be very, very difficult in clients, right? And the only thing what they mostly associate with is food, because food is something that all of us understand. So they would definitely want to talk to a nutritionist, talk to a person who is prescribing or suggesting their food more. They would definitely want to spend more time with the nutritionist because they're not understanding anything what's happening medically in the background, right? Whatever the doctor says, we are going to do it. Whenever they call us to come to the hospital, we do come there. But what is the process behind it? We have to actually travel one whole day, bringing the child in the bus or the train. So if you take a 24-hour recall of the child, it's actually not the food what the kid would eat on a regular basis. It would be anything instant and anything which is available in the during the commute, basically. So we have to be really mindful about these smaller simple things. So now coming to the case. So this is 8-month-old male kid, very low economic status. Mom's education was the 3rd grade and dad's was 9th grade. Dad was working as a construction laborer. Primary language spoken was local language Kannada. They could not understand any other language. And the bigger concern was the mother had two other kids at home who, she had to take care of 2 girls at home. So this was the 3rd kid, was a male, right? So anthropometric measurement when we first initially saw was 7.1 kgs. And I've just given you WHO references here. Length was 66 centimeters, height circumference was 41 centimeters. So development history, gross motor skills the child could sit independently. Fine motor skills were to transfer toys, language was babbling, and social smile was seen. Biochemical parameters shown HB 7.9, urea 36, creat 1.11, calcium was 10, sodium was 136, potassium was 5.79, and chloride was 108. So the final diagnosis was CKD stage 4 with bilateral hydronephrosis. Left nephrectomy was done during the stay, hypertension, anemia, and hyperkalemia. So with the recall, we came to know that the child could easily have one small regular piece of idli with coconut chutney, which was thinly made. No additional seasoning was used for this, 2 tablespoons. At morning time, milk with sugar. So this was packet milk, what we get, the Karnataka Milk Federation's packet milk with 2 glucose biscuits was consumed. Lunch was mashed rice with dal, 1 cup. Evening, tea was given with 2 glucose biscuits, and dinner again, repetition of the lunch. Right? Diet preference was vegetarian. They were not they could not start eating egg for this kid. Breastfeeding frequency was 4 times a day. First thing in the morning, afternoon nap time, night before bedtime, and once midnight. So the total recall value showed an approximation. So this is including the food, what he is taking orally and from the breast milk, approximately the total calories would come up to 850, 20 grams of protein, 460 mg of calcium, and phosphorus was 420. So according to STI, for energy and protein in children with CKD stages 2 to 5D, 6 to 9 month old, we could suggest anywhere between 72 to 82 kilocalories per kg per day. And protein was 1.1 to 1. The highest we could go was 1.3 grams per kg per day. And calcium and phosphorus, the recommendation here is almost matching the intake of the child. So calcium, of course, we wouldn't want to do anything with respect to calcium, but phosphorus is something we might have to take care of. Now, I would want to just open it to all of you. We have additional microphones.
Can you all hear me?
I have to use the mic. Oh. So what do you think we have to do now, right? Like, see, we have direct recommendations for calorie, we have recommendations for protein. This kid won't be choosing to get the dialysis done, so they were very clear about it. So trying to manage at least or to convince the child or the parents for another the parents for another, probably another 3 months down the line or 6 months down the line, we might successfully convince them to, like probably start a PV. But till then, what do you think would be the conventional therapy? How should we go about the recommendation? Should we stick on to the calorie recommendations as is? Should we go up? Should we come down? What should be the protein recommendations? And it also be all milk. Yes, exactly. But will that probably cut disturbance is already for the issue for the baby in terms of gut health? Okay, very nice. Then has anyone answered? The child was already on cow's milk, so that was initiated for 6 months. That is still 6 months. They were exclusively the child was exclusively breastfed according to the reporting. What post which this dog with milk and tea. So the question was, is there any gut issues? Were there any gut disturbance or gut health issues already with the counseling being started? Oh, already you mean? Because the baby is on milk for 6 months. Right, right. So this is 8 months, so 2 months down the line, I think would there be any effect? Is there any? No, not with this child though. No. But a very good topic. In many countries, I think till up to 1 year, we do not start, even in India, we would not start with additional supplementations of milk. So should we recommend to completely eliminate milk from the diet? Or should we probably bring down the breast milk? What do you suggest?
So that we are preparing the child for the future treatment. Yeah. So sticking with a little lower range of the nutritional values, keeping in mind the financial condition of the parents, is advisable.
See, calories would not be a challenge here at all because I think they are okay to
I
give
would
the same
suggest even
meal.
the protein also, if we can stick to the normal range of the requirement. He's managing as per the acidemia level.
Yes. Yes, and how could we replace those biscuits? What would you replace the biscuits with?
We can go for some rice flakes or rice flakes or rava, suji.
Okay, so we would make using the same milk. We would probably add some rava to it
And
Or rice flakes to it and make a porridge kind of a thing and feed the child.
Sugar if you want the calorie.
Sugar, ghee,
Yeah.
just to increase the calorie part. Okay.
The vegetables are
Would it cause constipation though? Like, do you think it would other flowers with right, right. So last slide, I think Dr. Meenakshi also mentioned calcium is one part, but potassium is super rich in milk. And if we are using cow's milk, what ratio?
Half ratio of 875. Not with the full concentration. We can dilute F75 and we can start supplying. This all below this stage,
Right,
it's all trial and error.
right.
So every child is unique and every family is unique. So we need to consider all this.
So this practice of F75 you initiate during the stay in hospital.
During stay in hospital, it's little challenging. Suppose in case the patient's attendant says I can go back home and bring something.
Prepare and get the
Prepare and
feet and
come
then
back.
probably do it. So, but if they have to travel all the way back for 2
Only-
days and come back, then they
Only rice plant.
Rice.
Diluted
so the easiest option is rice.
rice plant or any
even you can have this rice flakes powder. So rice flakes powder doesn't need any cooking. Just hot water is there. You can
Yeah.
mix this hot water with sugar.
And absorption of iron is better comparatively. Okay, that's nice. So now coming to the elimination part, like we are not sure how much of breast milk is actually going in. Of course, because the mom has never tried expressing it and feeding it through Palada feeds. So we just estimated if we have to see how the mother's health is, how her previous children's growth were, and then we have to estimate an approximation of that much calories which I mentioned above is what we thought would really come from breastfeeding. And according to the mother's reporting, this was just for pacifying the child because whenever she's going to bed, probably that is when the breast milk is actually fed. So do you think we just continue this ad lib just for, capacity and then probably later, like only try to restrict cow's milk? Would that work? That would be best.
The rice flake has more iron than rice, you say?
Yes,
Is it?
yes. But is it really absorbable format?
No, ma'am. It was before they used to press with the iron thing. Okay, now.
Ultra
steel
processing,
presser.
yeah, ultra
Steel
processing.
presser. I don't think much difference.
Yes, yes, totally, totally. So, I mean, now everything is processed. Now we are seeing ultra processed products also in the market. So obviously the actual content would have definitely gone down. Yeah, yeah, I think that's it. Okay, so now consider, so now let's forget about this case. We'll just keep the case details. So imagine we have the same case with a well-to-do family where they can afford to go ahead with the, dialysis part. So this child will be put with the PV catheter. So what would the diet, what would the medical management, nutritional management be?
Probably start with oral if in case everyone is
Yeah.
and also make a proper diet chart where we'll be able to apply our details, right?
Example?
We probably keep them watching the vegetables as opposed to have watching the vegetables. We can make it more detailed. Because this child basically just having carbs, there's nothing else in the diet as such.
Right.
So
So even the dal and rice, what they're taking is a mashed portion and very, it's
minimal
not
amount of dal.
Yes, yes,
The protein can be very negligible.
yes.
If we make difference in terms of protein, potassium, and sodium and everything, well, we'll be able to educate them about what are things.
Upper weaning should be started. There are the higher level.
Yes.
Right. Can you just please elaborate on that? So proper weaning first, after 6 months, they have to go with not with mashed substance because the baby is 8-month-old.
Right.
So that has to be cut down and then proper counseling for the parents, what all should be included, like they can include khichdi,
they can include fortified and rice and dal, even chapati mash if the child is able to eat. And then proper timing. Even the breast milk can be altered by like proper sleep. So I see many patients, whenever the child cries, they will feed it, as you said, pacify. So we need to know whether the child is enough with breast
Getting
milk.
any nutrition from breast milk.
Yes. So if the child is often sucking, then we need to understand whether the child really feeling hungry or the mother is just giving a breast.
Offering the breast.
So when we alter the diet, like if the child is having 4-day meal correctly, then probably they will not need, sometimes the child will not need that mother's breast milk.
Yeah.
This all need to be considered and then we need to plan a diet.
So basically, you're just counseling them to improve the
Proper weaning,
weaning
Yes.
techniques, and then if orally the child is getting all the nutrients, then just breast milk would nothing, nutritionally nothing is added to breast milk. It's just okay.
the proper sleep of mother, both the mother.
Okay. Would you still consider breast milk's calories, or you will not? You will just concentrate on the
Then
oral
6 months,
food?
definitely yes. After 6 months, it is an added advantage.
Yeah.
What would you say, Dr. Like, breast milk should be considered post 6 months or not?
See, this is a bad diet, even if the child was not on sick leave.
Yeah.
So just taking it as an infant, generally, most of the times we find that the breast milk quantity comes down at 6 months. As a single nutrient, it's not sufficient.
Right.
But it's still providing your basic good quality proteins and other protective factors.
Right.
So at least till 1 year, we encourage breastfeeding. So we would not ask them to stop or substitute that.
Right.
What the child needs is adequate additional calories and proteins. Milk introduction, because he's already getting breast milk.
Right.
And we want to now introduce other foods, semi-solid foods,
Right.
and improve the variety and texture of foods that
Right.
is eaten.
Right.
So rice and dal being staple diet in all parts of India.
Yeah.
Whatever way they make it.
Yeah.
And then a little not too thin, not too thick, a spooning method,
Right.
which they can, that can be slowly enriched with the addition of little oil, little vegetables, etc.
Yes.
And a fruit that he can accept. The tea glucose biscuit should go up.
Yeah.
Because it's a total appetite destroyer.
Right.
You know, they feel full with that and then they don't.
Right.
So I think keeping the background now of seeking, choose items which won't add too much to his phosphorus and potassium intake.
Yeah.
And choose the right kind of food for him and the right kind of rice dal mixture with addition
Right.
as a beginning.
Right.
The alternative would be other cereals which are low in phosphorus and potassium, but those make it a little more difficult to find
Yeah.
other than rava or
Correct. 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 So we entirely swap this milk and, the glucose biscuit, which is happening twice actually. And we could just swap it with, like rava kanchi and other things. And probably a fruit which can be given an advice to this child. And in that time, like yes, so since the potassium was high with this child, but despite that, we have to, because when we eliminate the milk in both these times, we can easily add on to vegetables here, because that is something which is really missing in this child. Yes.
Major issue occurs at night. So if you're not giving breast milk, I think we'll have to give another form of milk at night. Because nobody will get up and prepare something for the child at night. Definitely will wake up at least twice at the night time. So we'll have to continue either breast milk or mother's milk.
No, yeah, so definitely we were still saying that like breast milk will be continued, probably just cut down the milk which is coming from
other
outside. The
I think
packet.
we can give milk in the form porridge or other form, not as milk and sugar or milk and glucose biscuit. I think we can give milk in preparations like the semolina porridge or something like that.
So the dilution factor, what she mentioned, right? Like probably use just 10 ml of it and add a lot of water and make the porridge. That's what you're trying to say.
But I think if others also agree, we can give it completely in cow milk or toned milk, whatever is available.
Yeah.
I don't think there's need to dilute milk in breast milk.
Okay. So
My
that's
suggestion.
I agree with that, everything that's been said about trying to improve variety and amount of solids in this child. But we do need to take care that if you're cutting out the milk and the sugar, which is currently having twice a day, that's a huge loss of calories. And it's trying to find the right amount and type of solids to replace that calorie drop, because you're getting at least 100 calories from each of those drinks, and to replace that with a vegetable, with it's got oil or ghee added to it, you're not going to get 100 calories from that. So again, it's just if you're taking something out of the diet, don't suddenly have a huge calorie drop because it's counterproductive.
so we would be actually like probably swapping it with something which is equally in the same calorific value or probably a little higher than that. Because this growth is in growing, child is in the growing phase. So we would always supplement additional calories, not just restricting the, the STI guidelines, probably a little bit higher than that, so that we know for sure that there is probably some amount of breast milk coming in, and additionally there are oral, like supplements which is going in the liquid form. So with dialysis, so what are the additional, like if this child is in, like conventional treatment without dialysis, till we really convince the parents to start him with dialysis. But instead, I mean, if you feel that the same child was brought to us, probably, like there would be some additional, like in the mid-morning, right? So, and there was evening tea made. Instead of tea, there was milk with Horlicks given, or, like any additional, whatever is available in the market is given. And the child is okay to get the dialysis, right? Once the dialysis catheter is inserted, everything after some time, what would change? Would the same requirement, the recommendation what we discussed right now, would that still hold true for this case?
Same recommendations, we can adjust the protein.
Protein would go up.
You can keep it closer and space. With the same, whatever the recommendation.
Right.
Extra protein can be added. So by the time the child will be around 9 months, we can start with the egg. The moment to make
Child is vegetarian. So what would we do? Yeah. Tell me.
It's the same thing. Dal. See, protein making
Paneer.
protein is I think we can do it with a slight alteration.
How high would you go in protein?
Protein is not a recommendation. What for the age? Whatever the recommendation for the age. I don't think so. We need a very high protein dialysis also.
Okay, so the KROKI guidelines is followed. Anything additional that I'm missing, because it's been quite some time since I've heard. So anything additional, Dr. Smith? We just discussed, this is the case. Right, so it's an 8-month-old kid. I just go.
No, you don't have to go behind me. I'm sorry, I missed the portion of.
No worries, no worries. This is a child, 8-month-old. Right, so economic status is super low. They're not ready to
Child
go
is
ahead.
vegetarian, now going on dialysis.
No, they are not ready to start dialysis. Not ready to start dialysis. This is the recall. So the child is having this idli one in the morning with chutney. With morning and evening, there is milk going.
So objectives are increase the calorie, increase the protein.
Yes. No, that's the discussion, what we were doing. We were just discussing how it's managed conventionally without dialysis. And if dialysis is there, what additional things we would recommend. And what are the types of food which is available right now in Indian market?
Child is a weight of the urine output is there.
Is urine output.
Weight of the baby. Weight of the baby. What is the weight?
7.1.
Anybody else want to say? Yeah.
No, I
For 8-month-old with CKD stage 4. Oh, okay. You're asking you a question. Yeah. Okay, okay. No, it's not.
So we have separate CKD guidelines, right? We have KDOT guidelines, we have PROT guidelines. So according to that, we come to this calculation. So this is what is the recommendation. We see 1.1 to 1.3, we can go as high as 1.3. Multiply. Protein. Yeah.
And considering the time is a security station.
Very good question.
The range that you see there for the 6 to 9 month old, the 1.1 is the lowest safe protein intake, and that's from WHO figures from 2007. So I agree this child's protein intake needs to be gradually increased because he is uremic and is probably suffering some of the consequences of that. So I think one would gradually decrease the protein intake towards that lower level of 1.1 kilo. But what I feel really the daily managed in order to guide you how much you can need to decrease the protein or keep it, not maintain the protein. So I wouldn't change the protein intake and say, okay, that's it. It needs to be monitored very carefully so you don't undershoot and give too little protein, because you want to promote as good growth as possible, and you shouldn't go below that figure, the figures you see in the left-hand column there, because that's the lowest safe protein intake from WHO.
So as we see here, I think approximately from breast milk around 5 grams of protein is coming. So now we will not be considering the breast milk because we'll only be thinking the oral feeds what this child is eating, concentrating our protein in those aspects. Anything else?
So water will be as recommended by the doctors. So the fluid intake, we'll have to talk to the doctors. Sodium intake.
Yes, yes.
But since we are cutting down the cow's milk and skids and all, to replace that with porridge, we can use finger millet, ragi.
Yeah.
So that is very high in iron, calcium. So this child requires high amount of calcium, iron, potassium is there. But one meal, since we are
meal,
cutting
yes.
down the milk,
Yes.
we can add 1 meal of that. Add a teaspoon of ghee. That
Ghee
gives
to the-
good amount of calories also.
Right.
So another
Right,
thing
and,
is,
and I think the amount the child would eat would be very little, and
Yeah.
because it really blows up. The preparation of ragi is such that if you put even 1 teaspoon and then add some milk, and that really thickens it up. So it will add some volume. So volumetric wise, probably if you have to consider the potassium would be very little, we can still add it here.
that's what I think. So you can add a fruit like apple. Since there's hyperkalemia, you can
Right.
replace it with cut apple, small pieces.
Small pieces. We could also mash the apple, steam the apple and then give it.
That is what can replace, I thought, in this time.
Right, 100%. Thank you. Any other suggestions?
And one more, what Arpita just said, ragi is a very frequently used complementary
Feed.
feed here, at least in South of India. A lot of us use it in infants. It's one of the first complementary feeds to introduce to babies. And I think speaking about its nutrient value is very important so that we also understand whether it's right practice to recommending a child with an infant with CKD.
Yes.
So we use very little amount of ragi. So the powder, you might use only 1 spoon, but it thicken up the feed so much and it comes to a volume of say 150 to 200 grams. And the total potassium in it, although ragi is very rich in potassium. I don't think because you're using very little quantities, the potassium wouldn't matter in that. So many of sometimes we are asked whether potassium is going to be. My parents read it up on the internet. Ragi is very high in potassium, but I'm getting that to ask me to cut down on other things. Why don't we cut down on the ragi? So I think that's a good to do this in our context.
And even for our, like dal here, as we saw, the rice and dal is mashed, like very little quantity of dal was used, and only dal water is what we start
when we wean off the child, we'll start the weaning process. So there is nothing, if you have to see Dr. Meenakshi's slides, it said that, dals are super rich in potassium, but we probably are using just 5 grams of dal. So this is absolutely safe, especially for a vegetarian population. We could actually go up in that. We can use up to like 10, 15 grams per meal and try to equally, like balance rice with it so that there is enough protein and everything. Yes, if they are able to afford, why not? Yes, we should. Pre-mixes. If their literacy level is good, if they can make it at home, of course we could do it. Or if we have available those which are available in the market and mix it with rice flours or ragi flours along with that, and then yeah.
You want to reduce the protein.
Yeah, to some extent, because composition is very important. Sago and arrowroot might bring in a lot of constipation issues, water retention, so we might have to add in some fluid. That is, yes. You were there, yeah. So,
Yeah.
yes. So you just see the bioavailability is actually very different.
Correct. Yes. So I thought rice, dal, and all those things. Only milk we can consider as a high vegetable value protein, but dal and rice would be low vegetable value protein.
Correct.
And you go 5 grams from the breast milk.
Right.
Why can't we just add a mashed chickpea, like a kind of hummus? So that can be given along with the boiled vegetables as well.
But we could definitely try, because we are trying a lot of new food for the child, and we
Even
are
that is
introducing
also
many.
economic.
The child likes it because
Correct.
that's very important. And
Correct.
what is the quantity the child would be eating?
It's very
And
less.
how is the tolerable factor, how exactly the child is taking it. If we assess all of these things, of course, we have a number of foods like this, which could really, we can start off at least for the texture and the flavor.
Correct. Because I thought, okay, the whole person, as you told, he or she is a vegetarian.
Yes.
Can go for the high vegetable value from the sources of the vegetarian kind of
Yes.
diet.
Yeah.
So which will be like lentils and whole pulses as well.
Right.
So that can be eaten and boiled as well if we just consider on.
Yeah, so we have to
potassium.
probably really concentrate on cooking methods here,
Cooking
because the digestion of whole pulses is very difficult for the pediatric population.
That's
So
what
we
the
have to
mashed
try.
form, hummus.
Right.
So something like that along with the vegetable can be given, so the minerals as well as the calories and protein,
Right.
everything that we met. At least 1 serving per day would do.
Yes, 100%. Thank you. I think that's it.
So the child is actually vegetarian. If you are able to convince, we can definitely.
If non-vegetarian.
If
then
non-vegetarian,
is it
we can.
Are we supposed to add first yolk and then white?
So
or
actually, that is the process for any healthy child. We start with the yolk and then go for the whites. Here you can see, you can try with, because the whole egg yolk would not, child might definitely not consume that, right? So we might have to try that and then move to whites and see if they are tolerating it, and then give only whites after that.
What's the thought, like, eat FCTs, if not milk, the cow's milk, that is the issue, that before 1 year they should not be able to lead to anemia, will worsen the anemia even more. If affordability is not the issue, then can we start with any formula which is available in India?
Yes, we can.
So,
But we
the
have to just
FCTs,
look at the,
the rest of the things with ARF and high calorie vegetables, supplements, and all the addition of jaggery, oil, at least to meet the FCTs, we can add available formula pills.
we could, I think, yes, we can do that. Thank you. Any additional points?
Problem we face when we introduce too much milk and say some amount is okay. Their children are very milk dependent and then they don't transit to home food and normal foods. So if the breast milk is reasonably good, then milk as an additive to your porridge, etc. is fine. But milk as milk makes them very dependent on liquid food and they don't graduate to texture.
Right.
And then it constitutes.
Yeah.
then you find it very difficult to beat them off after 1 year or more. So we have to do it right when we do it from the beginning. We have to appreciate it. The reason why we may be a little hesitant to take the suggestion of understood sounds good is also when we are trying to introduce other foods in infants. I'm talking about children. We don't want to introduce substances to which they may be allergic or have allergic, increase gut permeability. Some of rice, moong dal, etc. are all being very hypoallergenic and they tolerate it better. So when you introduce other proteins, you have to be a little careful. I mean, it's not been tried, so we can't say it's but just
I'm not talking about the PKD kit, the normal, kids who come in OPD with constipation and anemia is they're just on milk diet. 2 liters of milk they're having, and they're not having. And that's easy. That's it. They have their own buffaloes and cows at home, and they keep on feeding the child milk all the time. Having prominent.
Got one other point about potential allergens being introduced into the diet. Just to say, if a baby is being breastfed whilst those potential allergens are being introduced, breastfeeding is protected. So if you think that there is a family history of any type of food allergy, it's important to continue breastfeeding whilst introducing those potential allergens.
Thank you so much. And close this session. There are no more questions. Again, an excellent question. Lot of discussion. So we take a short break for tea now. So tea and snacks are served outside. You can take them and come into the following habits. We can have a 10 to 15-minute break.
Just add it.
I can stand it. Give a camera again. I'm not going there. Should I start?
Can we start the meeting? You can just sit down quickly.
Hi, so glad we had that break for a little bit of caffeine. So you're all alert and awake. Okay, so let's start with the next session. A very small case study on congenital nephrotic syndrome. Absolutely not going into the theory of what it is. Just wanted to decipher that infantile nephrotic syndrome is when it is at age of 0 to 3 months. 3 months to 1 year, it's called congenital nephrotic syndrome. So this is a case we had seen. The last follow-up notes with the nephrologist said that the child was 1 year, 2 months old with congenital nephrotic syndrome with SPL insufficiency syndrome. Height was 78 centimeters with a Z score, which was normal length for age. Weight 10.2 kg with a Z score, normal weight for age. There was approximately 400 grams of weight gain and 4 centimeter weight gain in 4 to 6 months. So a not very good increase in height or weight, but he was near his required height and weight. The mother's weight and height is given here. The child was able to walk, speak monosyllables. Urine output was good. He was off albumin infusion since 6 months. Cholesterol was 360 milligram. Creat was 0.26 milligram per deciliter. Albumin 1.8 gram per deciliter and an IgG of less than 360. At this follow-up, his tablet atorva was increased and vaccination was deferred after 2 months of the IVIG. This is in general the medical the lab parameters that were plotted. There were a lot more, but I just concentrated on this. So when he was first checked in October of 21, he was having a urine protein of 574, which came up to 965 in November. What I was more concentrating on was the cholesterol levels, which were 366 in October and came down to 159 by January. And that should be January 22. Triglyceride was 516. The serum albumin also was lower. Total proteins also in the range of 3.5. Now, coming to the diet history, I have plotted the diet history right from the time the child was born. I saw him in the later phase, but at birth to 3 months, the child was on breastfeeding. At 3 months, he was shifted from breastfeeding to skim milk powder with MCT oil and sugar. I would like to ask you all, do you think this change was necessary, or what could be the reason for this change? No, it was a medical reason that was given up for the change in the breast milk and shifting to the skim milk powder. No other reason for stopping breastfeeding except for the blood parameters and the medical state. Too many people speaking. Can you please raise your hands? Here, you want to say something? Come on. The question was that at 3 months of age, breast milk was stopped and skim milk powder was introduced. with addition of MCT oil and sugar to give the calories. So my question is, was this the right thing to do? Was it essential? And what could be the possible reason for this change?
The parameters of liquid profile might be on the higher side.
Okay,
So that may.
maybe may have told that this change is required. Okay,
And also skim milk powders, because to reduce the fat content in that, so the cholesterol levels, we have to consider that as well. So reduce the frequency of breast milk feeding and to increase to meet up the nutrient demand of the baby, we can start with skim milk.
okay. So you mean that to reduce the cholesterol and the triglyceride, the shift was made from the breast milk, which had more fats in it, to skim milk powder, which is having negligible fat content,
And also to meet the nutrient demand of the baby.
meet the extra energy requirements. Can our experts please tell whether this is a warranted move?
Can I just say something on this?
Yes.
When we choose on HCP oil, it's definitely a source of saturated fat, and we definitely expect a raise in the LDL cholesterol and total cholesterol, as well as TGS. So is it the right thing?
That's my
Especially in
question.
somebody with nephrotic syndrome where you have dyslipidemia.
Can we have this?
No, I'll tell you the reason, because this is my patient. This child had a chylothorax, which was very unusual. You don't normally see that in nephrotic syndrome. So this was part of the conservative management of the chylothorax. So to eliminate that and give some fat which you can absorb, that's why this unusual change.
So the point is that this congenital nephrotic syndrome is not just one thing that the child was having. The syndrome, the SLP syndrome that he was having, and the other medical issues were in place, and that prompted this decision. As we all know, chylothorax warrants no fat in the diet. If given, it is a very small quantity of MCT oil to give the necessary to the diet. Okay. At 6 months, the child was weaned onto certain weaning foods. The one thing that was started is khimti, as we call it in Marathi. It is basically a preparation made out of rice and moong dal powder with some dry fruits added to it. So it's a powdered mixture, dry mixture, which is the grains are roasted and blenderized and made in water to feed the child. Along with it, dal water and rice water was also started. The child was also started on egg white, boiled and blenderized, which he tolerated very well without any issues with allergies. So this is just a random example of a child tolerating egg white at the age of 6 months. So we need not be very, very cautious or very, very reluctant to start some high quality protein at a little earlier age, because we see a lot of patients coming to our hospital who are starting eggs at an early age. We need not wait till 6 months of age, or we do not fret, as Vanessa had said, if the child is already getting milk, breast milk, the tolerance is better to allergens. At 8 months, the mother started adding certain vegetables like carrot soup. At 1 year, a chapati or a roti was introduced. So the child was slowly moving from a liquid diet to a few very selective solid foods. The present diet suggested that he was having milk intake at 6 a.m., 1 cup with half a teaspoon sugar, a roti or chapati plain without any ghee or oil, and sometimes boiled potatoes. He doesn't eat any other vegetable besides potato and a little bit of tomato. At 11 a.m., he again takes the weaning khimti in water with ghee and salt and turmeric to add some flavor to it. 2 p.m., it's a simple lunch with khichdi. There is rice and dal and tomato with some salt and additional ghee. At 5 p.m., Monaco biscuits or Marie biscuits are his staple food. 5:30, she ensures that he gets his one egg white boiled every day. That comes at 5:30. At 7 p.m., apple juice or beetroot soup is added. 9 p.m. is again the khichdi with ghee, jeera, mustard, some Indian flavorings to make it interesting. And at 12 p.m., sometimes the child wakes up, sometimes he's fast asleep. So if he wakes up, the easiest thing for her to give is milk with sugar. Okay. So in this recall, considering this is a nephrotic syndrome, I would want somebody from behind to tell me what are the pressure points or the sore points in this recall. Anybody from behind? Please. Biscuits. Okay. What else?
Beetroot is rich in potassium.
He is a nephrotic syndrome. Right now, there's no issues with the sodium, potassium, phosphorus. Yes? Ghee. Cashews and almonds. Why?
Cashew especially, not almonds.
Considering the quantity that would go in that porridge, I don't think it would be too much to really make a difference, but it would add a little bit of proteins and calories. The fat shouldn't be such of an issue. Right now, there's no salt restriction, not many restrictions at present. Okay, next question is, how would you improve this plan? Quantities are not mentioned because it was very random. It depends on the child, how, when, what he wants. So no standard formula. So emphasizing more on the vegetables, a variety of vegetables you mean? Yes.
Fruits not added here.
Fruits are not added here. Considering it's a nephrotic syndrome, which nutrient you would emphasize on more? Protein. So how would you improve it? For example, his lunch. Lunch is a preparation of rice and dal, khichdi. So you'll understand the ratios of rice and dal in the diet. So how much protein would he get from that? How would you want to change the nutritional value of that meal? Increase the pulse content. Okay. What else? Any other foods that a child who is 1 year, 4 months can have? He's eating eggs. Yes. Non-veg foods. Okay. What other things would you do if he was a vegetarian, just eating eggs? Paneer, curds, soya bean. Very interesting. Do you know anything special how soya bean would be of help or of not of any help in nephrotic syndrome? Just remembered an interesting study that had happened at one of the places I was working. So we had done a study with the use of soya granules, the soya granules or the soya chunks that we get. And this girl had made a soya laddu kind of a preparation. It was basically a powder because soya is not sticky. So it does not make a ball or a piece as such. So this soya chunks were roasted, ground into a powder. She had mixed it with jaggery and very minimal quantity of ghee. And she had compared the protein, the albumin levels over a period of 6 months and the difference between the egg protein and the soya protein. And interestingly, what she found that the albumin levels were increased at a better level with the soya protein and rather than the animal source protein. So maybe we could include more of soya in the diet if the child tolerates it, if regionally they are okay with using soya in the diet. Now these chunks and nuggets and granules are very easily available all over. So this could be one of your sources of a good quality protein. The other thing I wanted to emphasize was the high biological value of protein we have been listening. And with nephrotic, it is very important that we emphasize the quality of the protein along with the quantity. We cannot overload the child with lots and lots of protein. We need to make good with the quality that we are giving. So even if he's a vegetarian, like we discussed yesterday, yesterday's talks, the quality can be improved by complementing the grains with the pulses or the dals, grains with some quantity of milk products, right? Or if they are non-vegetarian, part of it could be vegetarian, part could be non-vegetarian. And soya again has a very good role in nephrotic syndrome to retain the protein losses in the urine. Okay. Besides that, as we all pointed out, ghee being a saturated fat can be used, but should not be overdone. There should be a balance of the different types of fats in the diet. So counseling to make the mother understand that she uses different kinds of oil or uses the family food that is made for everybody in the house is a better idea. Okay. Anybody want to add anything regards this recall? Okay. This is the prescribed diet, a child 1 year, 4 months with whatever parameters we have. is having a mixed diet. The instructions given to him was to add minimal salt to the diet. That was 1/4 teaspoon per day. Add soft consistency foods instead of liquid foods, because we saw that the mother was more leaning towards liquefied or blenderized feeds, which was more fluid and less of the concentrated nutrients that she can give through the feeds. So counseling for adding more of a semi-solid kind of a food and slowly progress to the normal foods. Use of dry dates powder was suggested instead of the white sugar, so that the sweetening is available, the calories are available without having the simple sugars to increase the triglycerides. One whole egg or 2 egg whites were suggested, because as we all know, you'll get only 50% of the proteins from egg white alone. Adding the whole egg will not affect the cholesterol so much, but will give you the extra iron and other nutrients. Bakery products like biscuits and other stuff was advised to be avoided as much as possible. Salt intake should be curtailed with the exclusion of processed foods, rather than adding very, very minimal salt in the diet. Make the diet more palatable with regular use of salt. Sodium, potassium restriction only if indicated as per the parameters. Otherwise, it is not required. Nutrition prescription. Basically, for nephrotic syndrome, we see says that you try to reach the RDA for calories and proteins. Only if there is a very high loss of proteins in the urine, you compensate it. The PRNT also recommends that the initial prescription for energy intake should approximate that of a healthy infant. In those with suboptimal weight gain and linear growth, the energy intake should be adjusted towards the higher end of the SDI to promote optimal growth. So the suggested diet was something like this: a total calories of 1200 kilocalories, proteins 14 gram, and first class proteins out of that was 9 gram. I think this is more important than just trying to meet the protein goal with not really good quality of protein. So the morning milk was changed. Milk was introduced in a smaller proportion, half cup milk. We didn't want to change the mother's practice of using dry fruits. So we allowed for the dry fruit powder, just that we include, like Dr. Meenakshi was saying, we replace the cashews with the walnut powder, which would give a little bit of the omega fatty acids. And then we don't have to worry about the cashews, with dry dates powder and a little bit of flavoring in the form of elaichi or adding of a banana to make it much more calorie dense. Now again, the child's appetite is small, so he's using very small meals. So to cover up for that, we are making the feeds more concentrated. Not so concentrated, it becomes unpalatable, but adding variety in one go. The next meal was a dalia or a wheat porridge or a halwa. So she was making it into a thin khimti, which is basically in water. We tried to counsel her to make it a little bit more thicker, so that it gives a more packed calorie intake, with almond walnut powder to sweeten it up. It does dates powder, or sattu paratha. Sattu is a roasted powder made out of grains or pulses, and it is very good as a nutrient booster. So sattu can be used as a porridge, it can be used as a paratha, it can be used as a chila. So a suggestion was given to add this if she wanted to add variety to the diet. This was suggested with pureed vegetables, because the child is not into biting into pieces of vegetables. She has to kind of hide the vegetables and give. So a suggestion to add it to the preparation itself and slowly try to get a few pieces of the cut vegetables here and there, so that the child gets used to the texture. Then by 12 noon, mixed vegetable khichdi, or with again, so we've added the egg with the khichdi here rather than giving it separately. So whatever proteins come from the amino acid that come from the khichdi are complemented with the egg proteins to give a higher biological value. A small chapati with egg omelette or bhurji with some vegetables is also suggested. At 2 or 3 p.m. in the evening, a fruit. She's only giving him banana, so we have suggested to add some more mashed fruits, and so that there is a variety in the nutrients that he gets by adding some different fruits to the diet. Normally, we try to convince them by telling them that you need to add a rainbow to your diet. So try to include at least one different colored fruit to your, or a vegetable to your diet, so you get the variety of nutrients. Like I know since yesterday we have been talking about sodium, potassium, phosphorus, but besides that, there are multiple number of vitamins and some other factors which the child needs. And the processing that we do for most food cooking, I think takes away a lot of it. So just a word to remind them that the child needs a more than what is not being given to him. Around 5 p.m., a cup of mixed flour porridge with again a little bit of ghee or oil. We can suggest different soft preparations like pancakes, chilas, dosas. So it would be a step up from the liquefied feeds and the semi-solid foods to a normal food. By 7 p.m., a thick vegetable or a dal soup was given. I think I missed the dinner part. So dinner, yeah, it's the same as 12 noon. So a simple diet with the mother coming from a middle socioeconomic group can follow and make at home, not changing too much on what she was already giving and was correct. I think many times we try to do too many things and change everything that the child patient is doing, and that kind of gives a message that they are not doing anything wrong. But I personally like to emphasize the good thing that the mother is doing, and then there are much suggestions that we give to change in their present diet. I think they welcome it little openly. So I think that it is much more of a trick of the counseling than the diet planning. So basically, this was how the diet for the child was planned. And now this is in the phase when he is well under control, not in the acute phase. Anybody wants to add anything? That's scary. Everybody is kind of in shock.
When is holding hands?
Perhaps, I think this is an excellent description of what you're aiming for. But my question would be, does the mother have the time and the inclination to do it? Because it's very labor intensive, producing these meals very frequently throughout the day. They're quite complicated to make. And my question to you would be, how do you persuade the mother to invest so much time in preparing this rather complicated diet for her child?
So I was lucky to have a mother who was very compliant. She was trying a lot of things on her own. I just had to replace a few things for her and had to give suggestions as to how to make it easy. It may look a very complicated diet, but it is not, because most of the things are pre-prepared. You know, like the walnut powder, the dates powder, these powders are ready, or you get it ready-made, naturally made, not any additives. So it is just a matter of adding it. She was already making the soups and the blenderizing and other stuff. So we suggested she includes more of the home cooked food for the whole family. So that way she can also cut down on the effort she has to take. So these were few things, like the khichdi she was already making. We just scheduled it a little differently to make it a little bit more balanced and rounded. But you are right. And the mother is a homemaker, so it was not difficult for her. But for other person, the diet would have been a little different. The working mother, definitely. Or a person where the grandmother or the grandparents are taking care. Yes.
Could you add some protein powder to any of this? The child's still very young.
Yeah. Yes, definitely. A protein supplement would be okay if the intake is not good enough or they need. Yeah, definitely.
Just to perhaps to supplement and increase that protein without making so many other
Changes.
This
Yes.
is amazing.
Like it would be easier to make the morning milk with just a protein supplement rather than adding 4 different items to it. Definitely. Yes.
I have a question. So what's the Chinese to tolerate so much of dry dates powder, like it's 6 teaspoons a day plus 3 teaspoons of nuts powder?
Yeah.
So it's something which is too much for the child. So what's the reason to tolerate this? So whenever I recommend, I hardly go by 2 teaspoons a day for groundnut powder because it's cheaper. So 6 teaspoons, that is just my doubt.
So I don't think there should be an issue with that because it is spaced out. It is not like 6 teaspoons at one go.
It's 2 teaspoons and 75 ml of milk and that too with powder.
Yeah.
So it's too much of a mixture.
Absolutely, absolutely. And I think it is again individualized. You have to be on the lookout whether your child is tolerating and slowly step it up. Like start with maybe half a teaspoon, 1 teaspoon. And then there are other things that can replace the date powder, like a fruit or something else. So it doesn't need to be, I just kept it a little similar all the way, not too complicated, but it is actually very complicated already.
The first recipe that you're giving in the morning is milk powder, date powder, and banana. So what did you do? It like a
It's an
porridge?
option. Yeah, it's not a porridge. It's just
not
like
a
a
option.
blenderized. Yeah, it's a blenderized milkshake kind of
Kind
a
of a
thing.
smoothie that
Smoothie
you're
kind of a thing. Yeah.
Okay, thank you, ma'am.
Yeah.
You mentioned adding protein powder to try and make a more concentrated sauce, but would you ever just go back to using your skim milk powder again, as you did when you were creating the milk for the baby when he was 3 months old? And again, it's something that presumably families can buy from the shops rather than having something more expensive like a prepared protein powder.
Definitely. That would be one of the suggestions of using the skim milk powder and then adding on to it. Yes. Thank you. Thank you for your inputs.
Good noon, everyone. So I'm supposed to present a case on metabolic syndrome post-renal transplant. So everybody knows about the metabolic syndrome, I'm sure. So it is based on finding of at least 3 abnormalities such as obesity, elevated blood pressure, low HDL cholesterol, hypertriglyceridemia, and hyperglycemia. So any 3 of these is it counts for metabolic syndrome. Now, the criteria for clinical diagnosis of MS in childhood and adolescence is central obesity plus presence of 2 or more than 2 components. As I just said, HDL, this is on the lower side, like higher waist circumference, lower HDL, higher plasma triglycerides, high blood pressure, high fasting glucose. So this is a pathophysiology of metabolic syndrome. Now, definition of this in children according to the International Diabetic Federation is like from 6 to less than 10 years of age, obesity, this waist circumference more than or equal to 90th percentile, and metabolic syndrome cannot be diagnosed in this age group, but further amendments should be made if there's a family history of metabolic syndrome like type 2 diabetes or dyslipidemia or cardiovascular diseases, hypertension or obesity. From 10 to 16, less than 16 years of age, again, this is more than equivalent to 90th percentile. this waist circumference or adult cutoff if lower, triglycerides more than equivalent to 150 milligram per deciliter, HDL less than 40 mg per dl, and BP also like 130 or more than equivalent to 130 for diastolic and more than equivalent to 85 for the other one, and type 2 diabetes, it is 100 ml per deciliter, or known type 2 diabetes recommended on OGTT. So use existing IDF criteria for adults, and central obesity, one has to use the cutoffs, the regional cutoffs. Like these are like the Asian cutoffs are different than the European cutoffs. In the children, this above 16 years of age, again, this is reduced HDL, like the things which we already, I already put up, reduced HDL and, raised BP, impaired fasting glycemia, all these things. This is the criteria for the adults, but in any case, we are talking about kids today. So this is a case study of subject is a 17-year-old boy. He was going to be 18. His BMI was normal. He had no history of abdominal obesity, elevated triglycerides, or hypertension. You can see the profile. This is CBC and renal profile tests. HB is very low, and all the RFT tests are quite elevated. Serum urea and creatinine, everything is quite high. Now, before transplant, this child, this adolescent, he was like, the height is 172, weight is 70 kgs with a BMI of almost 24, and waist circumference and hip circumference like 81 and 90 centimeters. Now, before transplant, this patient was on hemodialysis. Like from 2018, August 2018, date of transplant was August 2020. So 2 years, this patient was on hemodialysis. Type of transplant was swab. Now, biochemical parameters before transplant, if you see, they're all, normal. Lipid profile is normal. HDL and everything's okay. The lipid profile I'm talking about. Now, this was an advice on discharge. Now, all these medications, like they're all immunosuppressants and antihypertensive drugs. Now, these are the anthropometric parameters 1 month after transplant. There was within 2 to 4 weeks, this child lost 20, almost like 16 kgs. So what can be the reason? What can be the reason of this drastic weight loss? No. It's parent. Yeah. Why? I mean, what was the reason? Yes, he was on immunosuppressants. Anything else? Okay. Yes, but reason for that, like what? Any other reason for that?
Kidney was working with transplant.
Yeah, it's that. I mean, he's now saying okay.
Kidney in his little stomach.
He was 17-year-old.
Yeah, he's just a 17-year-old child. So he was about to be 18 years old at that time. So, it might be due to, increased catabolism, high dose of glucocorticoids, or GI distress. I know he had diarrhea. It was, so all these things were there. So there was a, rapid weight loss. Within 1 month, there was a rapid weight loss. But after 2 years of transplant, it was noticed that there was a decrease in HDL, increase in weight, increase in waist circumference, increase in plasma triglycerides. Like, it happened in 18. So in year 20 now in 22. Now the situation is this, that his weight is 82.5 kgs now. His sugars were fine. His lipid profile, this went in for a toss. So you see the all the the cholesterol is 204, HDL is reduced, triglycerides, and then LDL is 118, VLDL is around 39. So these all went for a toss. So present medications are all these. So you can see this is a prescription he was given. So several metabolic processes are altered by kidney transplant, mainly due to mechanism of overlapping between pre-existing favoring conditions, yo-yo effect on body, like weight loss and sudden weight gain. So this is a type of a yo-yo effect, and side effects of immunosuppressive agents. Now, among the metabolic alterations commonly observed after the transplant, diabetes or dyslipidemia, uric acid metabolism. So it was dyslipidemia and central obesity for him. So these were this thing. So mainly due to the clinical impact, they may present not only in relation to graft function, but also in terms of patient survival. So these are some of the reasons that the recipients and patients with autoimmune or inflammatory conditions, which can be a cause of renal damage or an associated comorbidity, require treatment with immunosuppressive medications. Of course, then this calcineurin inhibitors, particularly cyclosporin, increases LDL cholesterol level by a number of mechanisms, including reduced binding to the LDL receptor, decreased bile acid synthesis, and promotion of glucose intolerance. Although cyclosporin and tacrolimus seem to have similar actions on lipid metabolism and glucose intolerance, use of cyclosporin is consistently associated with increased levels of LDL. Now, if we see the diet recall of this patient, because he was feeling hungry and he was a child, he was like, adolescent. So I just highlighted the things which, like the paranthas, all the fried things, biscuits, bhujia, and salted peanuts, and again biscuits. I mean, it was a junk he was having. So the focus was, because when you take a diet recall, and you just need to focus on the things in very small details rather than changing it completely. If you change it completely, the patient is never ever going to have a good compliance with that. So you just focus on 3-4 things which you need to change so that he's able to do. That is very important. If I change it completely, okay, you have sprouts, you have this, you have that, it is just not possible. So just change those things with the things which are doable. So this was energy was 2300 calories, protein 55, total fat was quite a lot, and carbs 270. Okay, before I show this slide, I introduced one thing in the diet, that is psyllium husk. So any role, anybody can tell me what's the role of psyllium husk, or commonly it is called isabgol, constipation, and yes, satiety bhi hota. And the way his lipid profile there was had gone for a toss.
Soluble dietary remove some of the fat.
Yes, so I'll come to it. So we advised a diet low in salt, high in fiber. So of course there were fruits and vegetables were missing, so they were put in the diet. The use of psyllium in the food for 3 weeks or longer lowers blood LDL cholesterol in human beings with increased LDL cholesterol and lowers blood glucose myas in human beings with type 2 diabetes. Use of psyllium for a month or longer produces a small depletion in systolic blood pressure. So, and he was also told to avoid this is the initial stages to avoid high risk foods. Now, again, I would emphasize on the, this is the very important thing to be, even if you're taking a diet recall or telling a patient that what to eat, you need to tell him via pictures or via food models, so that the things are very clear about the portion sizes, else everything goes for a toss. So diet plan suggested, again, you can see psyllium husk I have added, then homemade soup or salad, seasonal fruit, because all these things were missing. Then low fat milk was advised. The rest we kept the same, so that, there are not so many changes. There's biscuits and aloo bhujia. They were, they were swapped with seasonal fruits, lemon water, or roasted chana, sprouts, nuts and oil seeds, anything. There are good nuts and oil seed mixtures available in the market, non-salt. So take home messages that immediately after transplant, first 4 to 6 weeks, please do not be, over enthusiastic. Now the transplant is done and now the high protein and high energy, high calorie diet. No, because it can have its repercussions, like the way it did in this fellow. The products including or based on milk as well as rich in fiber should be excluded to avoid GI distress, since it is the patients are prone to that, to GI distress, dysphagia, diarrhea. They're often observed in early weeks after transplantation, which often result from immunosuppressive medications. Therefore, an easily digestible diet is preferred. So there in PGI, what we prefer is giving them whole dal, moong chilka dal khichdi. That is 60% of that dal and 40% of rice, along with a bit of curd. And then we put around about 35 to 40 grams of mashed cottage cheese on that. So it's easy to digest as well as high in protein. It has fiber as well because it is moong chilka dal, but it is quite palatable and digestible. And we put a lot of some vegetables like, ghee sort of thing, so that they're soft vegetables. We put vegetables in that only. So it is called Nutri Khichdi. So there are 3 types of khichdis in our department. So this khichdi goes in one to these patients in their earlier days after transplant, and then one it goes to the CLR, the labor room for the for the ladies. So yes, recipients' physical fitness in the early post-transplant phase is limited by the low activity level from the dialysis period, of course. Early post-operation stage and frequently suboptimal graft function, anemia, fluid overload, and mineral disturbances. So as soon as there is no contraindication, patients ought to perform moderate exercise for at least 30 minutes, 5 times a week. So it is as true for the kids also. Treatment of metabolic syndrome, both in general population and in children with CKD, is aimed at reversal of insulin resistance and normalization of metabolic and hemodynamic abnormalities. It may be achieved by reduction of mitochondrial load, by a decrease in substrate availability, a decrease of fatty acid reflux to the liver, and increase in number of mitochondria. The first aim may be achieved by calorie restriction with dietary modification, leading to a decrease in GI. An increased amount of fiber in the food may decrease fatty acid reflux. Physical exercise and an increase in lean body mass leads to the formation of new mitochondria in the liver and in skeletal muscles. Dietary modifications with significant limitations of sugar, especially fructose. Now, kids, they are more prone to having more fructose in their diet, all the juices and everything. In the diet, it has been found, because parents tell me that, okay, this fruit juice is better than Coke. No, not at all. So both are as bad. It has been found effective in terms of both the normalization of metabolic abnormalities, decrease or stabilization of carotid intima media thickness, and improvement of endothelial function assessed by flow-mediated dilation in children with metabolic syndrome. However, when dietary modifications and physical exercise were combined, this FMD of the artery was much more improved. The important observation is that after stopping an exercise program, this decreased to basal values. So it's a lifestyle, lifelong, and it has to be a behavioral change and like a lifestyle thing. Now, in adolescents with MS, 1 year of non-pharmacological treatment based on physical activity alone or combined with blockage of renin-angiotensin-aldosterone system resulted in a decrease of prevalence of metabolic syndrome by 50%. And the main predictor of improvement was the decrease of face circumference. So to conclude, all transplant caregivers should keep in mind that nutritional management is an important defining factor of health outcomes in post-renal transplant and should become a foundation in improving patients' quality of life and hopefully the outcome of their graft. To achieve appreciable metabolic results and beneficial effects on graft outcome, a customized and active. What do you mean by a customized and active diet plan? Anybody? Yes. Yeah. Yes, it is tailor-made. One glove cannot fit all the hands. And what do you mean by active? I mean, right from, if we catch those patients right from the beginning, I mean, then the way this patient had a weight loss and a weight gain, this might not happen. This approach should be used for any specific patient, possibly starting from the pre-transplant period when possible. Thank you.
Thank you, Nancy. And of course, Rukshana did have concerns about having obesity because we might not be looking at too much obesity in the context of CKD initially. But post-transplant is a group where we look at lots of obesity, and even outside of CKD, if you see, we have endocrine clinics referring patients with obesity and hypertension. It might not be CKD yet, but then we are asked to give diet advice and lots of lifestyle modifications for these children. So that's the context of discussing it today. I'd love to hear from all of you because you might not, even though if you're not working with renal patients, I think most of you would be giving advice to obese kids on what to do and what not to do. I'd love to hear, please do open up and tell us what you do and what could be done better.
Circumference is what we measure usually.
We're not taking waist hip measurement is what is done, is it? Generally, waist to height ratio is not considered.
No, but this fellow was, around 18, almost 18. So he was almost 18. So waist hip circumference we took.
Okay. Even for adults, waist to height ratio.
I think a specific thing for obesity is the waist hip ratio, and that's central fat, central obesity is a very easy measurement and very specifically links to cardiovascular health. So it's an easy thing to measure, and it's an easy thing to tell your patient to monitor regularly as well.
And waist height ratio and neck circumference is often picked up with reference to cardiometabolic.
And the neck circumference. All right, I didn't know about that, but that's but I don't know about that research, but certainly the hip waist is relevant.
So I mean, if waist is higher, it is also higher. So
Sure,
we are not
sure.
getting to the anti-measure. So waist to height ratio and then be less than 0.5.
Sure.
So that would give a better clarity. Because something lupus is stunted.
Yeah.
With waist and hip.
That's really interesting. I think obesity post-transplant is something we see everywhere.
Yeah.
These kids who haven't eaten for years, all of a sudden are on a almost free diet. So that's a very big issue for sure. It's in the CKD population. In my reading, the obesity is seen only in a few countries, specifically in the US, Mexico, and in Saudi Arabia. And I think that links with the general obesity in the population. But obesity in children is a massive issue and sadly getting worse and worse.
What is it like to add?
My question is, experience that my nephrologist do not allow post-transplant to manage this metabolic. He doesn't allow fiber in any form, like in commercially available form also, neither in sales of an index sales form. So what he suggests is that it will interfere with the action of immune suppression. So he doesn't allow. What is your advice on that?
Initially, of course, we cannot overload the patient with fiber, as I told you. And it's not only 1 month, it's like it goes beyond 1 month. It has to be soluble fiber, We have,
not in the initial 10.
No, but what type of fiber are you talking about? You're talking about the supplements.
Yeah. It's
No, but why India doesn't require commercial fibers actually?
It's a full.
No, see, he was.
I think the awareness of the importance of fiber is growing. You know, in the past, it used to be thought of as treating constipation and that's it. I think increasingly the health benefits of fiber are enormous. And as Nancy showed, even with controlling the lipid profile, and therefore part of the metabolic syndrome, it's really crucial. So we've just literally maybe this in the next month, we've got 2 articles in pediatric nephrology, one on macro, they're both available open access. One is the benefits of fiber, which are only being realized in adult populations with big randomized trials. And therefore things like the Mediterranean diet or the DASH diet fit into that. And the second is management of constipation. And we are very soon, and within the next 6 months, publishing our print guideline on fiber management. So I would very strongly recommend increasing fiber. And the only slight anxiety I have is the satiety. If you're desperately trying to feed your child and then you fill them up with fiber and they no longer eat, then that balance needs to come. And that's where I need Vanessa to tell me how to manage that.
Yes. So I've seen maybe the patient was on thyroid, I saw somewhere. So that could be the reason why there was a drastic weight loss. But what we have seen is soon after the child is after the transplant, the child is put on omnicortin and all those immunosuppressants. They gain fast and they line up in no diet.
So he lost in 2 weeks, start 2-3 weeks, he was like, and then he gained. But the fiber thing here, the xylem, it is, it cannot be, if you see the Indian diet and if one eats normally, there's a hell lot of fiber in that. You don't need to add any supplements. The only thing is when you're treating a thing for a certain period of time, it is better to add a bit, like, he was having this, he had to be treated for that. So that I added. And in any case, he was not having any vegetables or fruits, so that way. But it has to be like gradual. 1 teaspoon is nothing, a small, it's quite light in weight, this xylem husk. So,
I think in the initial phases after transplant, some of us do advise them to avoid fresh cut fruits.
Yeah,
and,
that time,
because
that
we
time.
don't want them taking any,
Yes.
getting something unhygienic.
Yeah.
We don't want it. They are first 3 months.
It's like a neutropenic diet at that
So
time.
that time the fiber content obviously is going to come down in their diet. So transiently, as you say.
Yeah, he came after 2 years with such a weight, so that time.
Of course, the advantage of fiber is that it does fill the kid up, so it does automatically reduce the calorie intake. So fiber can be very useful from that point of view as well. I have to say, I've never seen a child who hasn't gained weight post-transplant. I mean, not in the immediate post-transplant, but in the longer term, they will inevitably gain weight at quite a rapid pace. And I was going to ask you if you have any psychosocial support for these kids, because I've found with girls particularly when they have their BMI has gone so sky high, they find it really difficult to cope with their physical appearance because they're not used to seeing themselves looking like that. And I wondered if you had anything like group clinics to give mutual support for your patients, or whether there was any kind of input you have to deal with psychological aspects of a different body image.
These kids, they are being referred to the to a psychologist to the department. But in any case, when we are giving a diet plan, it is just not giving a diet plan. It actually involves everything around. So you can't, giving a diet plan is an art and a science and emotional things, everything. So it can't be just doling out a diet plan, and it'll be just a total failure if we do like this. So it is, we have you can see the psychological counseling is also there along with giving the diet counseling, but of course there is a separate wing in PGI, so they are referred over there also.
More, I think we realize even in our endocrine and obesity clinics, especially post-COVID, we see many kids landing off with obesity and hypertension and all that. So at least we have the luxury of multiple pediatrics subspecialties in our hospital. So endocrine clinic routinely suggests to the patient that they see a child psychologist who then speaks to them about body image and all that. But I'm not sure whether this luxury is available in many centers and whether parents are sometimes the difference between a psychiatrist and a psychologist is not very well understood. So the minute you suggest you go and see a psychologist, you get a very weird look. And probably you're not going to see the patient and then in your clinic.
Yeah, that is true.
So that is a very, very true situation here. Yeah.
We have the same thing. The moment we have the same issue. The moment you mention psychologists, people just back off. If I may just say one thing from a medical point of view, the child losing so much weight in the early post-transplant period, if it's not fluid, I would be extremely worried, and I'd be investigating them with renal biopsies, even whole body CT scan and a bone marrow biopsy, because I'd be fearful of EBV lymphoma. And that's very high, very early phase where you give massive immunosuppression. So fortunately, your patient didn't have any of that, but it's highly unusual to see. We do, as somebody mentioned, you can get diarrhea with MMF, mycophenolate, if you use that, and that can be a problem, especially the younger kids. But if you haven't identified a distinct problem like that, this is a big red flag for malignancy. So just a cautionary word about it.
Any other questions? If anybody wants to share what you do for your patients?
I would like to add in a general obese population of kids, not referring to the CKD thing. You said now how the kids won't have the xylem husk and all. So one way to give them, and it was successful, was to make a kheer out of it, like, and yes, put it in milk and add a little bit of sugar or jaggery and put a little bit of nuts, and the child enjoys it, and a hell lot of fiber goes and he doesn't even come to know. So I mean, this I have tried in my setup, so it works.
So we can break for lunch now, and so nice. I know lunch is coming very quick after it's almost one now. So thanks for a very nice session, Nancy. And just an announcement before breaking for lunch. So those of you who have got a travel run,
கரெக்டா நான் தொட்டதான் வேலைக்கு ஆகாது. அது என்ன ஜிங்ஸ் இருக்குதுன்னு தெரியல எனக்கு இதுக்கும். எஸ் மேம். நல்ல காசு. இது ஒன்று அங்கே கொடுத்துருங்க. Good afternoon to one and all. I know it's a lazy afternoon and almost the fag end of the session. Before I start my session, 3 cheers to Dr. Sukanya. Vanessa ma'am. Yes, definitely. All the nephrologists, senior dietitians, and the delegates who have joined in today to make this really successful. And we want to hold on to this momentum. What Vanessa ma'am and Sukanya ma'am as well as Shroff ma'am have initiated, I'm sure this initiation has been for the benefit of us firstly, and definitely we want to pass it on to the patients. So once again, a big round of applause for them. Thank you so much. So I'm going to be talking to you of a topic which I think there's not a single person in this audience who does not know about it. But formally and in a structured format, okay, I will share some few slides, but definitely we would want your inputs as to how truly this big problem can be sorted out. In fact, there is one research paper which says Andhra Pradesh, they consume as high as 49.5 grams of salt per day. Can you imagine? Still 49.5 grams is like a number, but there's a research paper on it saying 49.5 grams of salt has been consumed in Andhra Pradesh. I don't know how they consume or what they're consuming. It's like a large number. So anyway, with this big number, so we move on to sodium, which is very, very critical in all organ failures. You call it whether it's renal failure, cardiac failure, liver failure, we talk of sodium restriction, and food becomes poorly palatable without that pinch of salt in the diet. So an average Indian consumes as high as 11 grams of salt per day, 119% more than the recommended limit of 5 grams per day by WHO. According to the India Spend analysis of a study conducted by Australia-based George Institute of Global Health, that is GIGH, published in the Journal of Hypertension, intake of excess salt can lead to high blood pressure, CVD, and it's not a known fact, or it's a known fact rather, I would say, that CKD comes next in the list, and not known by many, but important to be known by everybody is CA stomach. So excess of sodium intake is also a very, very high risk factor for gastric cancer. So salt intake in India, it is an alarming situation. This is based on the 2019 paper, according to which salt intake in India is high, and the research confirms it mainly comes from added salt. If I will show, skim through a few pages of the various food groups which we consume on regular basis, you will see there's hardly any sodium present in most of the food groups which you and me consume, which are non-processed. The focus needs that we need to implement a program to achieve the WHO salt reduction target of 30% by 2025. Now, I'd want to share some light on this. Most of the processed foods have a minimum of 7% to beyond 30% of your RDA in one serving. One serving of what you and me eat, if it's a processed meal or a processed pack, if you want me to be very blatant and open, a pack of instant noodles, 70 grams, will give you 33% of your RDA, adult healthy RDA. Then imagine for the pediatric population, your RDA is much lower and the consumption is crossing 50% of your total sodium requirement per day. So that's the damage done by the processed foods. So the focus needs to be on changing consumer behavior combined with low sodium and salt substitution. But remember, the salt substitution should not be done with potassium containing salt substitutes, especially when you're cat on the wall. Probably when you're in the pre-hypertension, hypertension, overweight, obesity stage, where you've not walked into CKD, frank CKD, probably in the early, CKD stage 1 also, I'm not very sure. But after CKD2, we do not know when our potassium will pick up. So safer bet not to go with potassium substitute once you've been, declared that CKD stage 2 or 3. So the impact is large. I don't think I need to go through this slide and the mechanism also, but this is the data. This data is as old as 2015, according to which, look at this. In Andhra Pradesh, I was making a mistake. It was not 49.5, it is 42.3 grams of salt per day. And the number of subjects were 1,429 subjects. It's alarming. So we joined. Where's Sukanya ma'am? Can we ask him to take over? Vanessa ma'am? Yeah, he has joined. So do we ask him to take over now? You can talk to him. You can mute. Yeah. Ma'am, he has joined.
Fabio?
Hello, everybody. I cannot hear you.
Is this something?
And the mic.
No, just a second. No.
Can you hear me? I cannot hear you.
Yeah, now you can speak. Fabio, can you hear us now?
Hi. Now you can
hello,
hear you.
Fabio.
Oh, nice to see you.
It's 9 o'clock in the
Morning or
morning.
good afternoon, maybe. Good afternoon.
Is the mic on? Hi, Fabio. I think hopefully we've got connection now. Sorry about all of that business just now. Welcome to our meeting.
Thank you.
So this is the first meeting that we've had of pediatric nephrologists and pediatric renal dietitians in India. So it's an inaugural meeting of getting all of our experts and learners together. And I'd like to welcome you to this meeting. Dr. Fabio Paglialonga is a pediatric nephrologist in Milan, in Italy, and he's been a member of the Pediatric Renal Nutrition Task Force since we started in 2017. And Fabio has taken over to be the lead nephrologist of the task force. He took it from Roxana last month in November. So Fabio and I co-lead the task force. He's in charge of the doctors, I'm in charge of the dietitians. So welcome, Fabio.
Thank you so much, Vanessa.
Taking over the leadership of the task force.
Thank you.
Fabio is going to talk to us today about the dietary management of sodium. So let's hope that the technology works and we can get the benefit of your expertise. Thanks, Fabio.
Thank you so much, Vanessa, and thank you to the organizers. It's a great pleasure to participate in this meeting, so thank you so much.
Good morning, Fabio. I'm Dr. Sukanya, so you've been getting all those emails from me.
Oh, thank you. Thank you. Nice to
very
meet
much
you.
for
Thank
Yeah,
you.
nice
It's a pleasure.
Thanks for joining today. So we'll start with your talk. Would you be sharing your slides?
May I share the
Can
slide?
we do it now? Or?
Now?
Yeah.
Okay. Perfect. Can you see my slide now?
Yeah, we can see it. We can see it.
Okay, perfect. So I can start. Can I start? Perfect. Okay, so thank you again for inviting me. It's a great pleasure to participate in this meeting. Today we're talking about dietary sodium intake in children with CKD. And and first of all, I'd like to show you the impressive increase in the daily intake of sodium in humans over the centuries, and particularly over the last centuries. And the question is, are we done to eat so much salt? And is this okay for our patients with CKD? To answer this question, we'll look first of all at some physiopathologic effects of sodium in humans, and then at clinical data concerning healthy children, adults with CKD, and children with CKD. Starting with the first point, first of all, you know that the intake of sodium leads to the increase in serum osmolarity, which can stimulate the thirst at the level of the lamina terminalis in the brain. And at the same time, it induces the production of arginine vasopressin, which acts on the kidney tubule to reduce urine output. So basically, eating sodium means increasing total body water. And both directly by increasing serum osmolarity and indirectly by expanding volume, sodium intake can stimulate the production of some vasoactive substances, which act on blood vessels to induce vasoconstriction. And vasoconstriction means high blood pressure. These mechanisms are thought to play a major role in determining hypertension after sodium and water exposure, and they play a major role in determining the so-called lag phenomenon. The lag phenomenon is the delay between the normalization of fluid status and the improvement of blood pressure. We can take several weeks, and which is due to the long half-life of these vasoactive substances. But the story is more complex than previously described, and we now know that sodium is not only present in the body in osmotic equilibrium with plasma water at the same concentrations in plasma, but it is stored in some tissues, particularly in the skin and muscle, at a very high concentration. And this occurs because of the presence of some glycosaminoglycans, particularly in the skin, which can bind sodium at high concentration. The role of this tissue sodium is not fully understood, but what we know for sure is that there is a strong correlation between the amount of sodium stored in skin as quantified by magnetic resonance imaging, and the left ventricular mass of adult patients with CKD. And novel mechanisms leading to adverse consequences after sodium exposure are discovered every day. Please look at this study involving 8 healthy male adult volunteers who underwent sodium supplementation for 2 weeks. What we can see here is that after these 2 weeks, these subjects had higher blood pressure compared to baseline, which is expected, but they had also a significant increase in the number of TL-per-17 cells. TL-per-17 cells are lymphocytes and they're key mediators of inflammation. And why this happened? These authors were able to demonstrate that after 2 weeks of salt exposure, these subjects had a significant, in these subjects, the survival of lactobacilli in the gut were significantly lower compared to controls. So basically, the rationale is that in the intake of sodium can lead to change in the gut microbiota, and then an increase in inflammatory status, which can lead to adverse consequences, even at the cardiovascular level. But let's move to clinical data concerning healthy children. We have several cohort and observational trials looking at the effect of sodium intake in healthy children. And you can see here a meta-analysis of these trials. And even limiting the analysis to the high-quality trials, what we can see is that sodium intake was associated with an increase in systolic and diastolic blood pressure, the main effect being an increase of 0.8 and 0.7 millimeters of mercury for systolic and diastolic blood pressure for each increase of 1 gram of sodium per day. And here you have the last clinical practice recommendations published, which suggest an adequate intake ranging from 100 to 1,500 milligrams per day on pediatrics of sodium. They propose also a new index, the chronic disease risk reduction intake, which is basically the threshold above which there is an increased risk of comorbidities. And what you can see is that the upper level is 2.3 grams per day in adolescents. But as you know, the vast majority of children exceed the upper recommended limits. And this is true in many countries in the world. You have here data coming from the United States and from the UK, but the many countries in the world have the same problem. And this happens because sodium is everywhere. And sodium added at the table or while cooking accounts for a very minor part of the total sodium intake of children, the majority of sodium being directly added during food processing. So it's particularly difficult to avoid or to reduce sodium. And if you look at the major source of sodium, this data comes from Spain, but it's the same in many countries in the world. The major sources are cereals, meat products, dairy products, ready-to-eat meals. And these this data comes from the United States, and you can see the top 10 contributors to sodium intake are foods where sodium is directly added to during food processing. So once again, it's difficult to reduce this intake of sodium. What can we do? We can base on some experimental data. We can treat sodium like an addiction. What we know is that looking at twin studies, the most first important point is that environment plays a major role compared to genetics in determining food preferences for salt. This means that preferences can change and we can act on that. And importantly, if you reduce a bit by 25%, not so low, the amount of salt in bread, this is not perceivable by humans. And more importantly, if you are able to reduce sodium intake for 3 months, the preferences for food will change towards less tasty foods. So after 3 months, the patient will prefer foods with less sodium. This is really important to know to to manage our patients. So we can reduce the sodium intake of our patients without compromising the quality of life of our children. But let's move to data concerning adult patients with CKD. First of all, you know that CKD is one of the conditions known to be characterized by salt sensitivity, as well as premature birth, low birth weight, obesity, and so on. This means that if there is an increase of sodium intake, the increase of blood pressure, the subsequent increase of blood pressure will be much higher in case of CKD than in healthy patients. And actually, we have several randomized controlled trials looking at the effects of low sodium diet in adults with CKD. And you can find here the last meta-analysis of these trials. There are more than 20 trials with more than 1,000 participants. The majority of trials looked at patients with CKD on conservative treatment, but some of them were enrolled also patients on dialysis or kidney transplant recipients. The mean difference between the low and standard sodium group in these trials was 73 millimoles per day. And what we can find here is that low salt diet was associated with a significant reduction in systolic and diastolic blood pressure. The mean difference between the two groups being 7 and 4 millimeters of mercury for systolic and diastolic blood pressure, respectively. But it's important to underline that the benefit was not only on blood pressure, and you can see that the patients on low salt diet had also a lower level of albuminuria compared to those on the standard diet. And you know how important it is, albumin excretion, as a progressive factor of CKD progression. And you're not surprised to know that the last KDIGO clinical practice guideline recommend to reduce salt intake to below 2 grams per day in adult patients with CKD with hypertension. And let's move to data concerning children with CKD. In this case, both the KDOQI and the KDIGO guidelines are in full agreement in recommending a reduction of sodium intake in children with CKD with hypertension or pre-hypertension. But the problem is that basically we have very few data concerning dietary sodium intake in children with CKD. This data comes from the CKD study in the United States. It is a cross-sectional analysis of children with GFR between 30 and 90. And based on food frequency questionnaires, they showed that the average dietary sodium intakes were above the maximum recommended intake for healthy children in all age categories, and independently on the patients being salt losers or not. Unfortunately, we have no data concerning children on dialysis. For that reason, we designed recently a prospective observational multi-center study in Europe. We enrolled 41 patients, median age 13 years, receiving thrice-weekly HD or HDF or automated peritoneal dialysis. The majority of these patients were hypertensive and oligonuria. In these patients, we calculated a simplified sodium balance based on dietary sodium intake, assessed by means of a 3-day dietary diary, sodium intake with medications, and urinary sodium losses, quantified on a 24-hour urine collection. Our primary outcome measures were blood pressure and, for children on hemodialysis, interdialytic weight gain. Moving quickly to the results, we had a median total sodium intake 1.5 milliequivalents per kilo per day, corresponding to 61% of the maximum RDI for healthy children. So much lower compared to the CKD data, but this was a completely different population, with the majority of patients being hypertensive on a sodium-restricted diet, anuric. And taking into account also the urinary losses with a median value of 0.6 milliequivalents per kilo per day, we had a median sodium balance of 0.9 milliequivalents per kilo per day, with a very pretty good normal distribution. We looked also at the effect of sodium coming from drugs. As you know, some drugs contain a huge amount of sodium. This is particularly true for sodium-based potassium exchange resins and for sodium bicarbonate. And actually, in our population, 30% of the patients were receiving at least one sodium-containing medication. And these medications account for 40% of the total sodium intake in this group of patients. And if we compare those patients receiving sodium-containing medications in blue with those not receiving this kind of drugs, you can see that urinary losses and the dietary sodium intake were not different between the two groups, but the total sodium intake and the sodium balance were significantly higher for those patients receiving sodium-containing drugs. So these kind of drugs are of importance and should be taken into consideration. This is not completely novel. If you look at the adult experience, you can find this data coming from the DOPS trial, involving more than 11,000 adult patients on hemodialysis. And what you can see here is that those patients receiving sodium-containing potassium exchange resins had a higher interdialytic weight gain compared to those didn't receive this kind of drugs, probably as a result of the increased thirst after increased sodium exposure. Coming back to our results, we did not observe any significant correlation between sodium balance and blood pressure in our group of patients. We have several possible reasons for that. First of all, this was an observational trial, and so the more hypertensive patients had probably a more restrictive sodium diet. Another possible explanation is that in the majority of patients, we assessed blood pressure by BPM, but the BPM was placed after dialysis in the majority of these patients, and so probably sodium intake plays a major role in determining pre-dialysis hypertension. Actually, we had a correlation between sodium balance and pre-dialysis hypertension. At the multivariable analysis, the strongest independent predictor of sodium balance was urine output, and this is expected. But the most important results of this trial, in my opinion, is this very strong correlation we found between total sodium balance and the median interdialytic weight gain in patients on hemodialysis. Please observe the very high R-square value and the very low p-value. The correlation is very, very strong. And in detail, we observed that patients with a sodium balance below 0.7 milliequivalents per kilo per day, and those with sodium intake below 1.5 milliequivalents per kilo per day had a very low probability of showing an interdialytic weight gain above 4% of body weight, which is associated with higher risk of left ventricular hypertrophy in children on hemodialysis. And at the multivariable analysis, once again, sodium balance was the strongest independent predictor of interdialytic weight gain in patients on hemodialysis. This means that basically our children on hemodialysis drink because they eat sodium, and asking them to restrict fluid intake without asking them to reduce sodium intake is unuseful and I think also unethical. But sodium balance is much more complex than this, and it's important not always only to consider the dietary sodium intake, but also the losses of sodium. And we can remove sodium by our patients, but by urine and by dialysis. And the first possible question is, do diuretics help in improving sodium excretion even in advanced stages of CKD? And the answer is probably yes. Please look at this randomized controlled trial enrolling 61 incident adult patients treated with CAPD, randomized to receive oral furosemide. Please observe the dose, 250 milligrams per day versus no furosemide for 1 year. And after 1 year, those patients treated with furosemide had a higher urinary output compared to those not receiving diuretics. But notably, the patients treated with furosemide had also a higher urinary sodium excretion after 1 year of treatment compared to those not receiving diuretics. So this kind of drugs can be of help. But what can we do with dialysis? We can remove sodium by dialysis, both in PD and HD with the ultrafiltration, so by convection. But we can also increase the amount of sodium removed by adding diffusion. To remove sodium by diffusion, we need a concentration gradient between plasma and dialysis fluid. And so in hemodialysis, what we can do is to reduce dialysate sodium to increase this difference between the plasma and dialysis sodium concentration. For this reason, we recently performed a single-center prospective randomized crossover trial comparing 2 different dialysis sodium concentrations, 138, the standard concentration, versus 135, the low concentration. We enrolled children and young adults below 25 years of age with hypertension, without pre-dialysis hyponatremia, with a low incidence of interdialysis symptoms. We randomized them to receive dialysis for 1 month with the dialysate sodium of 138 or 135, and then vice versa after 2 weeks of washout. The primary outcome measures were blood pressure and interdialytic weight gain. We enrolled 15 patients, and after 1 month, what we observed is that a low dialysate sodium was associated with a significantly lower interdialytic weight gain compared to 138. The mean reduction was 25%, which is actually impressive. And this was probably due to the better removal of sodium due to the more negative sodium gradient we had with low dialysate sodium. We did not observe any effect, once again, on blood pressure. This was probably due to the fact that we started to measure blood pressure just 2 weeks after changing the dialysis sodium, which is too early to observe an effect on blood pressure, given the lag phenomenon. I've talked about the negative consequences of sodium intake, but and it's important to remember that in some patients, sodium is not dangerous, but it's needed. This is true, for example, for infants with kidney dysplasia. This is true for children with some tubulointerstitial nephropathies. This is true, for example, for infants receiving peritoneal dialysis. We can lose a huge amount of sodium with the dialysis effluent. We have very few data about that in the literature. Please look at this report published 20 years ago on 24 infants with polyuric CKD receiving sodium supplementation, and compare with 12 literature controls and 48 historical controls. The message of this table is basically that those patients receiving supplementation had a better growth compared to the controls. So it's important to think about sodium supplementation to improve growth in children with sodium wasting disorders, but also to improve blood pressure, because, for example, infants in PD can be at risk of chronic hypotension. This can be really dramatic in this group of patients. And I would conclude. And to conclude, I would like to show you this picture taken in the San Marco Cathedral in Venice in November 19, just a few weeks after the last meeting of the International Pediatric Nephrology Association in Venice. After some days of high tides, this cathedral underwent flooding, and you can easily see the water on the floor. The water is dangerous for the columns, but it's relatively easy to remove it. But on the contrary, salt is basically invisible. It's absolutely dangerous for the marble, but it's really difficult to remove it. The same is true for humans, and the same is true for our patients with CKD. So please talk about it. Think about it. Thank you so much for your attention today.
I think it's a very relevant topic to our country as well, because Indians eat a lot and lot of salt, more than what you showed on your graphs for North America and Europe. I think there'll be a few questions from the audience to you, and let's see, we can take one by one.
Thank you.
Sir, it was an excellent presentation. Thank you so much. I wanted to understand the interdialytic weight gain. So by how many kgs was it lesser when you restricted the sodium?
So you are talking about interdialytic weight gain?
Yes.
Okay. Interdialytic weight gain is basically the difference between the body weight at the end of a hemodialysis session and the body weight at the beginning of the next session. So it is basically the amount corresponding to the amount of water the patient drinks during the interdialytic interval. And what we observe is that this is absolutely correlated with the amount of sodium they eat during the interdialytic period. And the sodium intake was the main determinant of interdialytic weight gain. So this means that actually the amount of water the patients assume between two dialysis sessions is for the mass part due to the dietary sodium intake. And so this was not an interventional trial, but what we can imagine is that if you reduce sodium intake, you can reduce the interdialytic weight gain. And this is particularly important because we have demonstrated that interdialytic weight gain is significantly correlated with blood pressure and with left ventricular mass index. So the most important point, if you want to reduce the left ventricular mass of your children, is to reduce the intake of water between two dialysis sessions. To obtain these results, you need to have a reduced amount of sodium in the body. So reduce intake of sodium between two dialysis sessions. And also I would add in better removal of sodium by dialysis.
Excellent observation. Thank you so much for this.
Thank you.
Fabio, do you have any feel for what the level of sodium in the diet should be in order to stop this swing in interdialytic weight gain? we're always talking about reducing sodium, low salt, but from your work, do you have a feel for any amounts that we could be aiming for?
Yes, we have some data coming from our trial, and what we observe is that our study was not designed to find the optimal levels of dietary sodium intake. But what we observe is actually that if we have dietary sodium intake, total sodium intake, including drugs, below 1.5 milliequivalents per kilo per day, and the sodium balance, so taking into account the losses of 0.7 milliequivalents per kilo per day, these patients, so with that total sodium intake below 1.5 milliequivalents per kilo per day, had a lower risk of presenting an interdialytic weight gain above 4%. In the previous study, we've found that those patients with an interdialytic weight gain higher than 4% of body weight had an increased risk of left ventricular hypertrophy. So what we suggest is to keep this value below 4% of body weight. And actually, in this cross-sectional study, we observed that those patients with that total sodium intake below 1.5 milliequivalents per kilo per day at the lower risk of excessive interdialytic weight gain. So this is, of course, this is not a randomized controlled trial. So I would be very careful when looking at this data, but this is something we observe in our trial.
Thank you. Thank you, Fabio. We now have the talk on sodium and how to reduce sodium in our Indian diet by Dr. Meenakshi Bajaj. We'd like to wait and also listen to the talk, and then probably we'll have even more questions for you. Is that all right?
I'm sorry, can you, I ask you to repeat because it's difficult to hear you.
So we have our next talk by Dr. Meenakshi Bajaj. So she's a renal dietitian from India.
Oh, perfect.
Yeah, she's going to talk to us about sodium in the Indian diet and how to reduce it. So we just quickly move on to the next talk. But if you can stay back for this talk and then take more questions at the end. Is that all right?
Absolutely.
Thank you.
Absolutely. Thank you.
Quickly concise. So I'll continue with what I was saying. So we have some data. Can you
Now, can you hear me?
Yeah, you can speak in the mic. In the mic, yeah, in the mic.
We go back to the old data. As early as 2011, I was making a mention that the Indian consumption of salt is as high as 42.3 grams in Andhra Pradesh. Against that, if you see, in and around, the salt intake has been as low as 8.5. I wouldn't call it low, but in the data which I'm presenting, 8.5 grams salt per day, based on the food frequency questionnaire done by Radhika et al. At Dr. Mohan's in Chennai, where the number of subjects were as high as 1,902 subjects. And we also have some data which was prepared by ICMR, wherein they found that 13.8 grams of salt was consumed per day in across 13 states, which is a large number of subjects. And in Tamil Nadu, once again, if you look at this data, you'll see most of the data is from southern parts of the country. And it looks like that the sodium intake in the southern parts of the country is high. So I think the nephrologist should tell us that how is the prevalence of CKD in the southern parts of India? Is it so?
No, it's almost the same. We have some regions which have more CKD in south, and there are some specific pockets where we
in Andhra Pradesh we have this Uddanam village where we have the CKD of unknown origin. Yeah,
but I don't think that's anything related to the salt intake. They're supposed to have a salt losing type of nephropathy. Yeah, yeah. It's not here.
There's some more data as early as 2017, which was published in the Journal of American Heart Association, which once again gives us information around a similar thing. But here, if you see that the salt intake in Andhra Pradesh, where the number of subjects were half, almost half of what they were studied in 2011. Probably, I think they've sensitized, the government has sensitized that you need to bring down your sodium intake. From the salt intake of 42 grams, it came down to as low as 9.46 grams. And it has been shown that it has been statistically significant with urine creatinine also. So there is some more data to tell us between the urban and the rural parts of the country. If you look at the consumption of higher proportion of salt from added salt came more from urban areas when compared to the rural areas. This is in comparison to Andhra Pradesh and Delhi and Haryana, where in Delhi and Haryana you are seeing that the intake is much higher in the rural areas. I'll give you one more eye-opening statement. The ICMR published data in 2020 as to what India eats. In that, they found that the ultra-processed foods have penetrated the rural pockets that as high as 4%. Whereas in the urban population, it is crossing 10%, which means the intake of high fat, sodium, saturated fat, and sugars, all of them have walked in. So if we look at that data and correlate it with the sodium consumption, I think we can get some more information, but that's yet to be correlated. But this data is already out that we have already penetrated in the rural parts of the country with as high as 4% with ultra-processed foods. So which means again, the ball was rolling with CKD prevalence. So the data on salt intake levels in India shows the consumption is around 11 grams per day, higher than the WHO recommendation of 5 grams per day.
You stand next there and you move magic slides.
Parogens. So we have the KWP guidelines. I'm sure all of you are aware of this, which does tell us that the earliest recommendation from the hypertension guidelines was to limit daily sodium intake to less than 2,400 milligrams. Then we had the guidelines from the cardiovascular and adequacy telling us that we need to bring it down to as low as 2,000 milligrams, followed by the American guidelines, dietary guidelines for Americans, which came down to lower than 1,500 milligrams. And finally, we have some guidelines to tell us that we need to bring it down to 1,500 to 2,400 milligrams of sodium. Remember, I request all our dietetic community to be very careful in their nutrition prescription when they are writing about sodium. They need to make a mention whether it is sodium or sodium chloride or salt. Most often we see in menu planning or in nutrition prescriptions, you will write 4 grams of sodium. Most often we see that. Instead of saying 4 grams of salt, we are not used to 1,500, 2,500. So we convert it and straight short write it as 4 grams of sodium. So be very, very careful. It's very important. And another thing, I will also tell you one little personal experience what I had. I had one patient who was fed enterally, and we had obviously the patient had hyponatremia, and it was not because of fluid overload. And the patient required something as high as 6 grams of salt. That's what was the prescription from the nephrologist. So we had very, very clearly written 6 grams of salt spread throughout the day in the enteral feeds, apart from the sodium which came from the enteral formula. And they had a special nurse. With due respect to the nurse, they usually don't do such mistakes. She provided 6 grams of salt every feed. Oh my God. Every feed. And the patient actually walked into AKI and obviously hypernatremia, and the vicious cycle went on. So it's very important as a nutritionist, not only to write the prescription the right way, but also to monitor and see what the nurse has for or what the caregiver has provided. Be very, very careful. And sometimes we say 1 teaspoon salt level. We need to make those so small pointers when you're talking to your patient or to the patient caregiver. That's always, if I'm to say salt sachets, it's unfortunate. I was discussing this with somebody this afternoon and telling them we have 1 gram salt sachets which are available, which are provided in the dietary services. You sit down one day and have them measured. All 1 gram salt sachets are not actually 1 gram. Either they are underestimated or overestimated. If it's just not estimation, the sachet does not actually contain 1 gram, either it's lower or more. So one needs to go with the measuring spoons, and I think we should provide it to our patients so that they are on the right track, and try and tell them not heat, it needs to be leveled. That's very important a message. And third thing, if they're using a finger, then 4 pinches of salt is 1 gram of salt. And another important thing is, when we say 4 grams of salt, we are trying to tell them that 500 milligrams of sodium will come from your entire day's diet. It comes from your pulses, vegetables, fruit, whole grains, everywhere. So 1 gram of salt will go away from your natural foods. The remaining 3 grams will come as an addition. So either you prepare the entire meal with 3 grams of salt, or you prepare it salt-free and then top it up with 1 gram per meal. For the children population, it's very, very easy. I would say it's easier in the sense that I usually tell them that 1 meal a day should be salt-free, strictly salt-free, apart from what sodium, invisible sodium, which is present in your food ingredients. So just have some curd, salad, obviously the low potassium salad if you think that the potassium is on the higher side or there is dyskalemia. Along with that, a low potassium fruit and some egg whites. So you're through, 1 meal is through. The other 2 meals, it's easier to handle. If you want to have, you have a sweet preparation, and the other meal could have the salt that you require. This way, it's easier to turn around to a patient and make it more palatable than telling that, split the salt throughout the day for all the 3 meals and including the snack. Becomes a little difficult. It's more easier. And as Dr. Fabio very beautifully explained that if you train the palate to a lower sodium intake, eventually you would not take too much salt in your diet. So it's just like we need to make our palate more used to taking low sodium, and eventually we will take low sodium. So obviously there is another area where we need to supplement sodium, as very beautifully mentioned. And obviously when the patient is on breast milk or standard infant formula, you need to look up at the invisible sodium. So this I made a mention to you this afternoon itself, that these are the different types of salts, and each of these salts contains sodium and potassium, and basically to use the regular table salt is more than enough. If you take rock salt, definitely it has lesser potassium when compared to the other salts, but the problem is measurement. If you have to take a pinch or 2, or you measure it on your teaspoon, it's very difficult unless you powder it finely at home level. Now the salts which are available in the market are the iodized table salt. So if we look at the sodium content, now I'm again reiterating, it's the sodium content and not the salt. The sodium content in iodized table salt is 2,300 milligrams per day. Kosher salt is 1,920, kosher salt fine, diamond crystal is 1,120. So either you can take a picture of this slide, there's no point me reading the numbers, but this is the sodium content in the regular salts which are available in the Indian market. Now it's important when I would say that I'll be talking no sense actually if I say that we live in a world without processed foods. So children most often do pick up biscuits and wafers and stuff like that. So the parent needs to understand how to identify the hidden sodium present in these processed foods. So before I move on to this, I would want to show you something else. Yeah. No, it's share. So this is a small snapshot from the book what myself and my interns, all of us put together and prepared this booklet. So if you look at the various food groups, you will notice that the sodium content is actually really low when it comes to the natural foods which you and me are consuming on a day-to-day basis. So look at this, the cereal exchange list. I'm talking about 100 grams of raw weight. The sodium content is all in single digits. Okay. Yeah. So look at the millets, you call it millets, pulses. They're all low, absolutely low in sodium. Look at even the vegetables, whether it's group A, whether it's a roots and tubers, whether it's a group C vegetables, whether it's the fruits, you hardly find sodium. So you don't have to actually worry when you're not added the salt to these food ingredients regarding the sodium content. Now look at milk and milk products. They also contain very low sodium unless it's a preserved or a packed, milk which you're choosing on. Yes, egg poultry whole, but that is also only 123 milligrams per 100 grams, which means it's approximately equivalent to 2 whole eggs. Then now look at this, prawns big. They are the ones, the seafood, obviously. When you look at seafood, in seafood is the prawns big, which is a bumper source of sodium. After that, we have the spices. We are not going to take in large quantities. It's all going to be in pinches. And now, that's where the problem comes. Look at the pickle. I just given an example of one of the pickles, which is commonly consumed in Chennai, which has 4,650 milligrams of sodium per 100 grams. And easily 10 to 15 grams walks into a meal if you're going to have yogurt and rice. And if you have a tasty vegetable as an accompaniment, you will have that. And along with that, you'll have either a papad or an appalam. I think you top up the day's sodium requirement. Now look at the most favorite of all, the Maggi noodles. It contains 1,286 milligrams per 100 grams, but I think a serving is almost 70 grams. And the must masala noodles is again 2 grams of sodium per 100 grams. So now I won't go into too much detail, but these are the numbers which you need to understand that they are all the processed foods which contain so much of sodium. So we have this small sachet of the savories, which somebody just watches a cricket match. If it's an India-Pakistan cricket match, you can't ask for. So many packs of chips will just walk in without even being told for. So similarly, if you're watching a movie, you're sitting across with friends, very easy to finish a packet of savories. So these are certain enteral formulas. Now look at the enteral formulas, which are the so-called renal-friendly formulas. They have the sodium content, but we are not going to be, when they are enterally fed, then you're not feeding them otherwise. You're feeding only these formulas, and easily you can fit into the 1,500 milligrams of sodium or 2,000, whatever is the requirement of the patient. So I think I'll stop with this. This is another important thing. One needs to know, as a dietitian, you cannot not know. I know it's the basics, but you cannot know the conversions. You need to know the conversions, milligram, milliequivalent, millimole, and conversion from sodium to sodium chloride. You want me to zoom this? Yes. It's all available in my diet metrics. But give me a moment. I'll try zoom. It's just enough. Is this enough? Oh, wonderful. Sorry. So what I've done is we prepared a renal exchange list with millimoles. It's much easier. And then you can convert it one shot. Okay, I just close this part of it. And I go back to my slides. Do you think you have the time to listen another 10 minutes? It's very interesting. So I've given you a clear picture as to what we eat every day on day-to-day basis, and the sodium content is hardly there, other than when it is processed. So these are certain now, as Sir previously mentioned in his presentation, that the food additives, they could be the preservatives, or they could be food additives which add on to the sodium content of the particular bag. So these are different forms of sodium. Sodium benzoate, sodium acetate, sodium nitrate, nitrite, which are used to preserve meat, or preserve jams, jellies, sauces. They could be either sodium nitrite, nitrate, benzoate, or it could be potassium nitrate, potassium benzoate, depending on what you want to preserve, the choice of the preservative, and most of them have either sodium or potassium. So this, I was talking to you this morning about monosodium glutamate. So after which I did little more reading to tell you some more about monosodium glutamate is. It is nephrotoxic, though there is a reduction of sodium intake by 37%, but it is considered as nephrotoxic. So I will show you some other additives which are nephrotoxic. For example, aspartame. We have a lot of type 1 children, obviously type 1 who walk into CKD. We have type 2 adults who walk into CKD. Those patients, when they consume artificial sweeteners, aspartame containing artificial sweeteners, they are nephrotoxic. They need not walk into CKD and then decide to call it off, but basically when they are nephrotoxic, we choose not to consume them if you are a person with diabetes. So sodium metabisulfite, this is very, very common additive, a very, very common additive in the preserved and packed foods. Now, recently, FSSAI, Food Safety Standards Authority of India, has published the food labeling guidelines in 2021 with a reference to when do we call a processed product sodium free when it contains less than 5 milligrams per 100 grams of solids or 100 grams of liquids. Very low sodium is not more than 40 milligrams. Low sodium is less than 120 milligrams. And it's always better if you can prepare. This is not the right guide, but this is just for you to understand that we use this traffic lights for sodium, for sugar, for glycemic index, glycemic load, or a healthy meal per se, to tell our patients who are not very well educated that if you look at the green, they are low in sodium or low in potassium or whatever. You know, where we want them to choose the low, we highlight it in the form of a traffic light signal. So there is some sodium content in different food products, all the frozen meats, canned, snacked, the meats, cheese, even the condiments, sauces, bread, cereals, drinking soda, all of them are sources of sodium. I would not want to go into each one of them, but definitely share a snapshot trying to explain to you that this is the product and this is the amount of milligram of sodium present in each one of them. So this is one of the favorite meal replacers. I would say children choose on this meal replacer, replacing their home cooked meal with a processed meal, and the sodium content in it is 815 milligrams per serve in India, whether it's rural India or urban India. And the sodium content in dairy products, if it is processed, yes, if it's not processed, no. This is the, I would say, bomb of sodium. They are not bombshells of sodium. There's so much of sodium, and we love watching on them. If you're sitting idle, sitting with friends, watching television, listening to music, bored, sad, happy, you want to choose on eating this. Please keep them off your dining table. I tell most of them to keep away from the dining table. The most important thing to keep away from the dining table is the salt shaker. First thing is that. Second thing is no pickle. Third thing is add deliberately less salt, and let, in India at least, the husband or the children on the dining table will shout and say, you do not know how to cook, you hardly added salt to the meal, But they will not get up and go to the kitchen and get the salt and add it to the meal. They will grip and eat it. So Mites will grip and eat it. For 3 days, 5 days, 7 days, they will grip and eat. 10th day, they will get used to eating low sodium. So these are the bhujiyas. And look at the amount of sodium. They contain 33% of adult RDA. 33% of adult RDA. So then you convert it to pediatric RDA. You'll understand how much of sodium is going into the diet. These are the savories, the most favorite. I'm sorry, I had no choice but put those images because only then the impact is there. This contains 7% of the RDA. And obviously these are the packed ones, the confectionery. Now this is what I was making a mention to you of, that you have the processed and ultra processed foods through what India eats. In fact, there is a paper with Dr. Anup Mishra and myself in which we have published the heterogeneity of the dietary practices in India. That was based totally on what India eats. And these are the ultra processed foods. Food labeling is very, very important. Now, if I go into each one of them, I need 1 hour separately for this. But understand anything which is processed, and we are processing our kidney towards seepage. So these are the list of the ingredients. Conversions are important. Strategies. Zip your lip towards the sodium intake. Automatically it will come down. The rule of 5/20 is when choosing a processed food, aim for 5% daily value or less in fats and in sodium. So this is the rule which we talk of. And salt intake can be reduced. There are several methods. First thing is addition of sodium, removal of processed food. So control, alt, del. That's what we use in our keypad. So control our portion size. No, I would say control the intake of processed foods, alter the portion size, delete the processed foods once again. So more than 75% of the consumed salt in India comes from home cooked food, meaning we are adding too much of salt to it. So salt substitutes, you have to be very, very careful. Enjoy home cooked, obtain nutrient content infection. Special occasions should be absolutely occasional. Avoid foods that are high in sodium, choose low in sodium. And remember, there are some alternatives to sodium containing compounds, but be sure that they are not potassium containing. There are some salt substitutes like rosemary, oregano, basil, mint, curry leaves, pepper, ginger, garlic. All these can be used as salt substitutes. And another important thing is Maharashtra, they use kokum. In North India, they use amchur. In South India, we can use tamarind, or we can use few drops of lemon juice or few drops of vinegar. All this will add to the flavor of our meal. So there are some people who add salt to the rice when they're preparing. There are some people who add salt to the wheat flour when they're preparing their chapatis. So they add some soda, that's the cooking soda, baking soda to the channa, rajma, all the whole grains for easier cooking. All these are packets of sodium which we need to keep away from. So reduce the intake by 30% and you can save your kidneys. So control salt del. Thank you for your patient listening. And we have 2 questions. Less than 5 milligrams per 100 grams of solids or 100 ml for liquids, not more than 120 milligrams per 100 grams, not more than 40 milligrams per 100 grams, which can be considered as low in sodium. A quick answer.
120.
Yeah, amazing. Big show of hands from Dr. Sugandhya. And the next question is, can somebody read it loudly?
Choose the best method among the options to help children lower their sodium intake. Do not add salt to the meal. Salt substitute, replace sodium chloride with potassium chloride. Avoid foods that are high in sodium, including soya sauce, luncheon, meat, ham, etc.
Yes. So what is the answer?
C.
A big show of hands for everybody. Thank you for your patience.
Thank you.
Thank you, Dr. Meenakshi. Lovely talk and with lots of pictures. I think bang on the on what you aim to achieve today. Be it too much salt. I think even Alan will be stuck with salt today. I know. Thank you very much. So, any questions from the audience? Want to share something?
All of us go salt free tonight.
Okay, so all of us can have a salt free.
We take a pledge and we go salt free tonight.
Okay. Okay, can you come here?
just one question, one thing, when you bring up your children when they're small, yeah, the children now when they are born itself, don't give them more salt because their taste buds are developed and so the threshold will be, they won't be satisfied if you don't give the salt later on in life. So it is better to reduce the salt when they are child itself, so that they will be active salt. So we have to see for the next generation. Thank you.
Just to comment here, because I think in my practice too, rather than just advising for cutting down on the salt for the child alone, it's always to cut down on the whole family salt, because anyways, most of these families are taking too much salt, and it's a general advice for the whole family. So also look at what the family is preparing for the whole, for everybody, and try and reduce that first. And that will have a huge impact on what the child is eating as well. Fabio, there are no more questions. Do you have any comments?
No, I first of all, congratulations for this nice discussion and for the presentation. I learned a lot from from your slides, and I think it was a very nice discussion about sodium, and with a lot of important points for the practice, for the daily clinical practice. So thank you.
Thank you very much, Fabio. Thank you for joining today. And we are coming to the end of this meeting. We've had an amazing 2 days. All of you have been lovely. The interest has been amazing. And I hope to have more meetings or discussions with both dietitians and nephrologists together in a room. And I think that's the way forward. I'd like ask Vanessa for some closing comments just before we close the meeting.
Just one final comment about salt. We've been talking about 6 grams of salt being the maximum that's recommended, or maybe even as little as 5. But just remember that isn't a target of how much to eat every day. It's the absolute maximum that should be consumed. And that 6 grams of salt is actually our requirements, plus 2 standard deviations. So our requirements are much less than that 6 grams. But all of the health authorities know if we aimed at our requirements, we'd fail immediately because there's no way we can eat that little salt. And it's going to take us a very long time, I think, for us as populations to get down to a maximum of 6 grams of salt a day. And obviously, as I said earlier, for children, for 1-year-old, the absolute maximum target is 1 gram a day. So we do need to, as our last commentator said, we need to train children's appetites and taste for salt right from the beginning when we start to give them complementary foods. So again, to thank Fabio again for joining us from Italy, and to thank everybody who's travelled here for this first meeting. I found it very enjoyable. It's been great to exchange ideas and to bounce ideas off each other. And I hope that this will be a start of a collaboration, a more close collaboration between the doctors and the dietitians, so that we can keep this momentum going. And I look forward to working with that core group on the PRNT resources so that we can make them suitable for your practice here in India. And it's not going to be a quick job. We might get something out this year, hopefully, fingers crossed, but it will be an ongoing program which will take us probably a few years to get the food lists, to get the practical guides for healthcare professionals, and then to look at the resources for the families. So I hope you'll be patient, but it's on its way. So thank you everybody for being so interactive and making this a very successful first meeting. Great to meet you all.
Thank you, all of you. So I'll now close the meeting. Bye, Fabio. And
Bye. Thank you again. Bye-bye.
thank you.